Good evening, everyone, and thank you, everyone, for joining for the webinar on Rewind 1. With immense pleasure, I would like to invite Dr. Lokesh KN, Professor and HOD, Department of Medical Oncology at Kidwai Memorial Institute of Oncology, Bangalore, for the welcome and introductory note. Over to you, sir.
Hello. Good evening, all. I welcome all of you for this wonderful event, the Rewind 1 2026. So, where we will discuss a lot of new upcoming drugs and also the updates, especially in relation to the ASCO 2026. So, we'll have a topic wise discussion. So, the first one is the breast cancer, followed by the lung today, and then tomorrow we have GI GU session, followed by the long hematology session is planned tomorrow. So I request all of you to join the meeting and utilize the opportunity. So first, I would like to welcome Dr. L.K. Raju, Associate Professor, Medical Oncology at Kidwai, to plan for the first talk, which is sponsored by Zydus. So over to Dr. Rajiv.
Good evening all. So kindly allow me to share my slides. Yeah. Yes. See my slides.
Yes, sir.
Fine. Good evening all. At the outset, I thank Dr. Lokesh and Rewind One giving me the opportunity. My disclaimer is Zydus. I thank you, Zydus, also for providing the PPTs. So, not wasting much time, I'll go to my topic. I will be talking present and future landscape of HER2 positive breast cancer management. As we know all the studies, I will be rushing through the slides, so we'll discuss in the later session. So all we know is FDA approved 8 molecules, the 5 maps, trastuzumab, pertuzumab, TDM1, TDX2, and margetuximab, and 3 TKIs, lapatinib, neratinib, and tupatinib. So we all well versed with the usage. So my topic, I rush through neoadjuvant, adjuvant, and metastatic. Before going to the adjuvant, we will just see what is a HER2 positive neoadjuvant chemotherapy. So the which patient we should consider neoadjuvant, especially in early breast cancer, irrespective of the hormone status. So we usually consider high tumor volume, that is breast ratio and tumor ratio, and lymph node positive disease, and high risk features like high grade, hormone negative, HER2 positive on TNBC, and young age at diagnosis where we want breast conservation also. So in general, tumors having more than 2 centimeter are not positive. We use neoadjuvant chemotherapy, especially in hormone HER2 positive. We use single or double agents or trastuzumab or pertuzumab. Why we use? So we know neoadjuvant pertuzumab. We know the PCR rates. So you can clearly see with these studies, Neosphere and Trifina, irrespective of the hormone status, we can see adding pertuzumab, there will be an increased uh, uh, pathological complete response. You can clearly make out with this bar diagram, and even irrespective of the baseline chemo also, the pertuzumab has a benefit of increasing the pathological complete response. So look back to the award-bound data, real world Indian data. So you can see the FESGO study. So this is one small study from the retrospective multicenter analysis. Here, they used almost 12 cases in the neoadjuvant study. So what they have seen, almost 75% pathological complete response in this study. The numbers are small, but they have a better benefit. So even this is one more study from the Hyderabad, the multi-center, Hyderabad and Pune. Again here, 12 patients are used. The PCR achieved in 10 patients. Almost 83.3% PCR is achieved. So if you see the other Indian data, So from the other biosimilar molecule, so in this data was published in ASCO 2026. The good number of patients, 219 patients, they are showing pathological complete response of 64%. That is a biosimilar to blockade. That is a Phesgo compared to the Phesgo. So in the real world, if you see the neoadjuvant Sigrima, most of the centers from the different centers also, almost 75 will 3/4 patient or 2/3 patients were achieved pathological complete response. So can we tweak from this regimen? This is a standard regimen. We have two trials, which NeoCARP and Helena 006. So where in the NeoCARP we can exclude carboplatin, or in Helena we can use any taxanes. So in the NeoCARP study, this is a study randomized 1:1. They have used carboplatin with other molecules, that is TCHP, without carboplatin. Good number, 387. So the primary endpoint they looked into was PCR. You can see the analysis of pathological complete response. So 64.1% was 65.9. There is a difference of 1.8. This is a pre-specified non-inferiority margin of 0.0089. So this trial achieved non-inferiority that excluding carboplatin has also equal benefit. So can we de-escalate from other taxanes? So here they are used weekly nab-paclitaxel, that Helena 006. So good number, 689. The again primary endpoint was seen as pathological complete response. You can see the pathological complete response rates with the nab-paclitaxel. So again, you can see the difference here in the all group, even in the HR negative, hormone receptor negative and positive, the benefit was shown with the using the nab-paclitaxel with the trastuzumab and pertuzumab. And if you come to the toxicity is less with the nab-paclitaxel. So it has fewer toxicity and better outcome, that is pathological complete response. So coming to the adjuvant landscape, this is one affinity trial, that is a phase 3 trial. We all well versed with this. They used chemotherapy adding trastuzumab and pertuzumab. So the ESMA 2025, the final results are out. So after 11.3 years of follow-up, you can see the updated results from the affinity trial. The intent to treat population, the delta is 1.8%. If you see the same with node positive and node negative, it has a higher 2.7%. This is a positive overall survival difference, but this margin is less with node negative, but intent to treat the all population, nearly 2% benefit. That is huge also. Coming to the other benefiting subgroup, you can see the subgroup, which subgroup has benefited. You can see the node positive more than 1, and even hormone positive almost to hazard ratio of 0.74 and 0.75. A huge benefit was seen adding pertuzumab to this. So after this trials, the adjuvant systemic therapy. So what they are used in the patient with neoadjuvant therapy, if they achieve pathological complete response, so you can go with trastuzumab, that is a category 1. But if there is a pre-specified neoadjuvant node positive is there, you can add pertuzumab also. Again, even in hormone negative and hormone positive, you can add pertuzumab if there is a node positive is there. So if node positive initially, pertuzumab has a benefit. So coming to the adjuvant, so here we all know that adding pertuzumab to the tumor, they have more than 1 centimeter or node positive have the benefit, and it is a preferred regimen. So defining the high risk, again, if you see the risk of 10% is risk of 10% recurrence is there, we consider it as a high risk. Those are residual tumor after neoadjuvant or any node positive or T4 before surgery. So these patients requires escalation to the TDM1. So what is the evidence? This is the Catherine study. Again, here they have used pre neoadjuvant, that is neoadjuvant therapy, at least 6 cycles of chemotherapy or 9 weeks of trastuzumab. It is randomized to TDM1 versus trastuzumab. What they looked, the primary endpoint was IDFS. So these are the publication SABC 2023. They published. It is a long-term data of 8.4 years. We can see the updated IDFS. So at the regular interval, they had the benefit which increased. So if you, for the benefit of PGs, I will tell this is 11, 12, and 13. That is 3 years, 5 years, and 7 years. If the absolute IDFS to benefit was 13.7% at 7 years. Again, there is a wide curves apart. You can see the IDFS benefit. So even if you come to the OS, again there is a difference. Almost here also 1.5, 3.7, and 4.7% at 7 years. Again, you can see the OS benefit, and this is the first therapy which shows the significant OS benefit at 7 years. So coming to the final IDFS, where the tumor means a small residual tumor, even with a small residual tumor also, the benefit is seen numerically. You can see the appreciate in the forest plot also, 74.6 versus 82. And even there is a below 1 centimeter negative axillary node, so the residual disease. Again, the benefit was seen. So what I mean to convey is that TDM has shown even with small residual tumors. So NCCN guidelines in 2025, it recommends if there is a residual disease, adult trastuzumab, that TDM1 is a category 1. After neoadjuvant, you have to give 14 cycles. So coming to this metastatic breast, what we can do in the first line? We are aware of Cleopatra study here, adding pertuzumab. It has shown almost 17 months of benefit with adding pertuzumab, that is OS benefit. And even if you look at the PFS also, again 18.7 months versus 12 months, and almost 6 months of benefit was seen. So coming to the one more trial in adding TDX to the pertuzumab, that is the Destiny Breast 09. So this is the interim analysis published in the last April conference. So what they have seen is the median PFS of 40.7 versus 26.9 months. That is almost nearly 14 months benefit was seen. But still we have to avoid for these data. The OS data is not yet mature. What is the monotherapy results? And we have to see the long-term duration and the safety also. And how many, there is a dose reduction of 46% in the TDM1, but we have to see those data, and only 32% has completed the TDXD therapy also. This data we have to see. Only 43% received the neoadjuvant therapy. That also maybe in future we can get the thing. So the PFS by hazard ratio, again the benefit was seen. Almost nearly more than 10 months of benefit of PFS was seen at 2 years. Coming to other trial, that is the PATINA trial. Here the palbociclib was included with the trastuzumab with or without pertuzumab. Again, here the PFS primary endpoint was PFS by investigator. So if you see this, median PFS is better with this almost at the end of 5 years. You can see almost 10% benefit was seen here. So the median PFS of adding palbociclib to the anti-HER2 therapy is almost 29 versus 44. That is almost 15 months benefit was seen with adding the palbociclib here. Then one more study, if you add tucatinib to the first line MBC, what is the benefit? So this is again international double-blind phase 3 study. They randomized tucatinib plus HER2 therapy. So with the placebo. So here the primary endpoint, again PFS by the investigator assessed. So what are the results? The efficacy PFS you can clearly make out in the bar diagram. So the delta is 8.6. So almost 16 versus 25. The median PFS by the investigator in the blinded control investigator, they have almost 16 versus 29 months, that were 12.9 months. So this, if you see the PFS by hazard ratio, it is sustained almost 12.3 months in the hormone negative and 7 months in the hormone positive subgroup. So in this patient, if you see the CNS PFS, with those patients have baseline brain mets, you can see the CNS PFS is almost double, 4.3 versus 8.5, adding tucatinib to the other HER2 targeted therapy. So what are the second line option where there is no predominant CNS involvement? As we are well aware of the TDM1, TDX2 and LabCap by the trial, you can see almost the PFS is nearly 9.6 in the CNS meds, and the maximum benefit was seen with the TDX2 was almost 29 months. So overall survival, again, the maximum benefit was seen with TDX. It was almost 52.6 versus 42.7. That is TDM1. The second line with brain mets, more than 50% of the patient with HER2 metastatic breast, they develop brain metastasis. So eventually, most of the trial, they will not exclude CNS metastasis. So this is the data where what we can do in a CNS metastasis. This is HER2 claim. They added tucatinib to the trastuzumab and capecitabine in previously treated HER2 positive breast cancer. They included brain metastasis also. So they added tucatinib to the standard arm. The primary endpoint is PFS. So the median line of therapy is almost more than 3 lines patients was taken. And non-CNS mets were 97% patients had non-CNS mets, and most 70% of the patient has received RT. So in this subgroup, if you see the intracranial response, it is 20% versus 47%, almost 27% benefit with significant T, the confirmed overall response rate. So the OS rate in all patients with brain metastasis, again, it is proved almost the median OS is 1 year versus nearly to 21.6. So even at 2 years, almost more than 14% patient, nearly 15% patients are surviving with tucatinib. The difference is 9.1 month of survival. That is the patient with brain metastasis. Coming to the intracranial activity of this tucatinib, even in the patient with active brain mets, you can see the CNS PFS almost 5.4 months, and overall survival is also 8.7 months. So you can see 64% reduction of CNS progression and 51 reduction in the death, risk of death. So HER2, though the possibility of a patient, those who have brain mets, you can delay next radiation or surgery in these patients, because in this patients, you can see this graph almost 14 versus 25, 11 months of benefit was seen. So you can save the patient with the quality of life, with a good quality of life without local therapy. So coming to the third line or beyond, there is we know there is no optimal standard sequencing beyond third line. So this is one trial.
Last 2 minutes. Sorry to interrupt. Last 2 minutes.
Yeah. 2 minutes only. So we have used in this trial, this is a small data. So there's a 2:1 randomization, adding tucatinib to the trastuzumab plus capecitabine. We can see almost 41% overall response and PFS of 7.6 months with OS of nearly 25 months, more than 2 years. So this, the ESMO has adapted this, adapted tucatinib in the second line and third line in active brain mets. So again, 2025 NCCN also included in HER2 positive tucatinib along with the trastuzumab and capecitabine as a category 1. So these are the Zydus molecules, the sponsors things. So to conclude my talk, so access to anti-HER2 agents are increasing. We have many, almost 8 molecules we have, and eligibility of patients should brought under neoadjuvant first approach. We know the benefit of neoadjuvant with Neosphere and Trifina, and tweaking from TCHB, removing carboplatin from the same regimen as a similar efficacy. And we know the affinity trial adding benefit of pertuzumab, and non-PCR still carry a high risk of recurrence. That so TDM escalation to TDM is one in the adjuvant setting, and THP remains the standard in HER2 positive metastatic breast cancer. And if the patient have brain metastasis, tucatinib is emerging. Thank you. Thank you for patient listening. I'm happy to take few questions.
Thank you, Dr. Raju, for excellent talk. Any questions? So with respect to carboplatin, now do you continue to use carboplatin or stopped using for neoadjuvant setting?
Neoadjuvant, I still use carboplatin, but wherever the patient are not fit for carboplatin, and the present scenario, we have carboplatin scarcity. So you can easily compromise carboplatin without compromising the outcome. That is what I feel.
Yeah, definitely. See, some side effect, definitely we can omit carboplatin. So even if it is stage 2, I try to omit. In stage 3, I try to use carboplatin. Whatever the data available, that's what usually I do for my patients. Okay. Any more questions? Okay. If no questions, thank you, Dr. Rajiv. We'll move on to the next session. Thank you. Next session sponsored by Roche. The continuum of care in HER2 positive breast cancer by Dr. Poonam Patel from Manipal Hospital, Bangalore. Over to you, madam.
Thank you very much, Dr. Lokesh. My job has been made very easy by Dr. Rajiv because it's truly continuum. We are talking about the same disease and some similar scenarios, except mine is a case scenario of an early breast cancer. Let me share my slides, please. I hope you are all able to see my slides.
Ma'am, it's coming. Yes. Just make it full screen, ma'am.
Yeah, I've made it. Is it seen?
Yeah, it's yes. Yes, ma'am.
Okay. So, as I said, that it is truly a continuum of the same discussion. And this is about a patient with HER2 positive breast cancer. As Dr. Lokesh has told, that this talk is being sponsored by Roche and the slides have been provided by Roche. This is the disclaimer. So we know that HER2 positive disease now, as Dr. Rajiv has told, there has been a paradigm shift. Earlier, it was considered amongst the most aggressive breast cancer subtypes. But because of sequential HER2-directed therapies, which we heard of, many of these patients achieve excellent long-term outcome. So I'm going to discuss all these things through a case, a relatively young woman, 40 years old with 2 children, medical history of hypertension and diabetes mellitus, and strong family history of breast cancer. So now when we heard from Dr. Rajiv about the risk, the adverse effects of the drugs, especially trastuzumab, we know that cardiovascular side effects are there with the drug. So hypertension and diabetes mellitus in a lady, a young lady, we should remember to evaluate the heart thoroughly. Strong family history of breast cancer. Though BRCA mutations are not very commonly seen in HER2 positive disease, yet because of her young age and strong family history, I would go with a hereditary breast cancer panel for her. So what were the disease characteristics? She had a left breast mass, 6 centimeters with skin involvement, axillary node. Biopsy confirmed it to be invasive duct carcinoma grade 3, hormone receptor status negative, and HER2 was 3 plus by IHC. The Ki67 index was 60%. So looks like overall an aggressive disease. with hormone receptor negative and HER2 positive, node positive, locally advanced disease. This was the PET scan at diagnosis. You can see that it is showing this locally advanced disease here in the left breast with skin involvement, and this is indeed an aggressive disease. But good thing was that she did not have distant metastasis. So whether this patient could be defined as a patient at high risk of recurrence? Yes, because she had lymph node positive disease. She had a high expression of Ki67 and large tumor size. She was hormone receptor negative. So what this shows is actually what all things do you see for recurrence of relapse for these patients. So what would you do in these patients? Would you give neoadjuvant chemotherapy? We heard from Dr. Rajiv earlier that yes, these patients with locally advanced breast cancer, HER2 positive disease, do benefit with receiving neoadjuvant chemotherapy. So sorry for this slide, not very clear, but this just actually stresses the fact that all patients with HER2 positive disease too should go through a multidisciplinary tumor board. And what is the intent of going through the tumor board? One is the diagnosis, second is the risk categorization, third is the pathway of treatment, whether it is surgery first or chemotherapy first, and what is the intent of surgery, whether it is downstaging the breast tumor, whether it's downstaging the axilla, and what would be the chemotherapy and what would be the monitoring methods. So all these things should be predefined before we start the patient on treatment. And what all things are we going to look for? So one thing what Dr. Rajiv had stressed was pathological complete remission. That was pathological complete response. How do you say that this patient is having pathological response or no response? So this is all defined by RCB, which is also known as residual cancer burden. It's an elegant research tool that quantifies the residual disease more precisely than what our YPTN staging would do. As you can see here, that there are 4 categories. RCB 0 is where there is no trace of residual disease, RCB 1 where there is minimal residual disease, RCB 2 where there is moderate residual disease, and RCB 3 where there is extensive residual disease. So this study actually incorporates the residual tumor size, cellularity, in situ disease. Very important is number of involved lymph nodes and the size of nodal metastasis. And there have been numerous studies which have shown that pathological complete response or RCB0 definitely does well. But as we move on from RCB1 to RCB3, the prognosis also actually keeps gradually worsening. So in routine clinical practice, treatment decisions after neoadjuvant chemotherapy are still primarily driven by the presence or absence of residual invasive disease rather than the exact RCB class, and RCB remains a highly valuable tool in prognostication and clinical trials. So for all patients who have received neoadjuvant therapy, we should categorize them into which class of RCB they would fall into. So this is the NCCN guidelines for HER2 positive early breast cancer. If the patient has no nodes and the tumor is less than 1 centimeter, we can proceed on with surgery. And after surgery, we know the final stage of the disease, whether it is stage 1 or 2 or 3, and accordingly proceed further as this algorithm shows. If the tumor clinically is between 1 and 2 centimeters, then we do an axillary ultrasound and check whether the nodes were negative or positive. If the nodes are negative, the patient can still go in for surgery first. But if the node is positive or if the tumor is more than 2 centimeters, then these patients should go through the pathway of neoadjuvant chemotherapy followed by surgery. Now, what neoadjuvant chemotherapy? Again, Dr. Rajiv has discussed, and the standard though is TCHP, but then as he had shown the trials where even the carboplatin was withheld and only docetaxel and trastuzumab, pertuzumab were given, had shown equally good responses. And this is followed by surgery. And then based on the residual cancer burden, we decide what treatment to give further. So all these guidelines, the international guidelines, which are NCCN, ESMO, AGO, and St. Gallen's, all recommend neoadjuvant systemic therapy for stage 2 or stage 3 HER2 positive disease, especially when tumors exceed 2 centimeters or the nodes are positive. And the rationale extends beyond tumor shrinkage, obviously, and this provides an opportunity to identify patients who require escalation after surgery. And without neoadjuvant therapy, we will lose this opportunity of reclassifying or reorganizing our patients. So for this patient who had a locally advanced disease, I don't think so there's a doubt. We would proceed on with neoadjuvant chemotherapy and then only go into surgery. So proceeding directly to surgery will not give these advantages. And this is what the advantages of neoadjuvant chemotherapy are, as listed, as Dr. Rajiv has also told earlier: downstaging the breast tumor, downstaging axilla, potential to decrease surgical morbidity, allows time for planning reconstructive surgery. It enables early response assessment and provides an opportunity to adjust the adjuvant treatment depending on the outcome of neoadjuvant treatment according to the residual cancer burden. It allows early treatment of micrometastasis as well. So in this, again, now what anti-HER2 therapy to give, whether we should give dual anti-HER2 therapy or single anti-HER2 therapy. Again, this is a repeat, sorry, with what Dr. Rajiv had already mentioned, whether we should give trastuzumab, pertuzumab, or we should give single agent trastuzumab. And as he had shown, these were the studies, the Neosphere, Trifina, where it was shown that the combination of trastuzumab and pertuzumab is what is going to give us the best results. So I will not delve on these slides. And trastuzumab, pertuzumab is recommended by international guidelines for neoadjuvant treatment of patients with high-risk HER2 positive early breast cancer. So the benefits we know: early eradication of micrometastatic disease. It serves as an in vivo chemosensitivity assay, and pathological response has become a therapeutic decision point, and patients with RCB0 go on to a different pathway of adjuvant therapy, whereas patients with residual disease go on to a different pathway. And again, this was shown that the patients who achieve a path-CR with neoadjuvant chemotherapy resulted in longer survival benefit than having a residual disease. And this was the pooled analysis, and pertuzumab, trastuzumab arm did better than trastuzumab alone. As you can see here in this table 7, that the event-free survival, this was in patients with path-CR. Now here you can see that patients who have already achieved a path-CR, and yet when we are following them, when they have received the dual anti-HER2 therapy, their event-free survival is still superior. So path-CR definitely is there, but we reach a notch above when we give dual anti-HER2 therapy. Again, this real-world experience from India was also discussed with Dr. Rajiv, and it showed that neoadjuvant therapy had patients, almost 83.3% had achieved a path-CR. And the patient satisfaction was also very high in these patients. So this patient, what I started discussing, received TCHP, and the HP was actually given through Phesgo combination, which is the subcutaneous injection. So she received 6 cycles, and she had an excellent clinical response with clinical resolution of breast mass and axillary lymph nodes. So one thing that we have to be very mindful of, that we should not assess the path response through MRI or clinical ones. Path response is pathologic only. We should just to do the surgery and then decide whether the patient actually has a path response or not, because PET responses sometimes can be very deceiving. So, any markers for PathCR at this stage? Yes, like how we have for hormone receptor positive, we have guidance with risk of recurrence scores. Same way for HER2 positive breast cancers, we have HER2-DX, and this is something that can be used to assess which patients could get PathCR and which patients may not get PathCR. Again, not much in use in India, but it is there. So this gives what is the risk of recurrence. It tells us the chances of PathCR, and also talks a little bit about the mutation which the patient may be having. So it integrates clinical variables with tumor biology, including immune activation, HER2 signaling, proliferation, and luminal differentiation. So this is only specific for HER2 positive breast cancers. And as I told you, its potential applications would be to predict PathCR, estimate recurrence risk, and identify patients suitable for treatment de-escalation. So the TRAIN-3 study showed that 1/3 of patients who had hormone receptor negative and 1/6 of patients who had hormone receptor positive breast cancer achieved PathCR in first 3 cycles of dual HER2 positive early breast cancer. So there is a higher chance to stop chemo also after 3 cycles in hormone receptor positive breast cancer. So this patient underwent left modified radical mastectomy in December 2024, and she had a residual disease burden of YPT2N0. And she was still ERPR negative, as was studied in the resected specimen. The HER2 status was 2+ by IHC. It was confirmed by FISH to be positive. Lymph nodes were negative. So here we came to another decision point, whether we should continue Phesgo or continue trastuzumab as a single agent or switch over. And as was discussed with Dr. Rajiv earlier, the Catherine study had shown us that starting the patient on TDM1 or Kadcyla in a patient who had residual disease, they had a superior survival benefit. So this patient is also on Kadcyla, was also started on Kadcyla due to residual disease and tolerated the treatment very well. So the lesson here is to optimize treatment in adjuvant setting for patients who have residual invasive disease following neoadjuvant therapy. As we saw in the real world scenario, almost 82% of patients achieved PathCR. So there's a good 20% of patients, nearly 1/5, who will not achieve PathCR. So they are the ones which is important to re-stratify them into a different adjuvant therapy, and that is where Kadcyla comes into picture. So the Catherine trial demonstrated the benefits of adapting treatment in patients with residual invasive disease after neoadjuvant therapy. Again, these slides were shown by Dr. Rajiv, so I will not stress on them. And TDM1 is recommended by International Breast Cancer Guidelines for patients with residual invasive disease after neoadjuvant therapy. So there was a doubt. Supposing this patient had residual disease less than 1 centimeter with no axillary nodes, what would he have done here? Now, this patient had YPT2, so that was a different thing. But if it was a small residual, what should have been done? So the Catherine study showed that even if the residual disease was less than 1 centimeter with negative axillary nodes, still there was a significant risk reduction in risk of recurrence compared to trastuzumab. So such patients also should ideally receive TDM1. And Kadcyla or TDM1 can be safely given along with adjuvant radiation. It can be given along with concomitant along with endocrine therapy also, without any increase in adverse events. So again, this was already discussed by Dr. Rajiv about the Catherine study. And this was the 8.4 years analysis that was almost 101 months, and it showed an absolute IDFS benefit of 13.7% at 7 years. Again, kind of unmatched. And it showed a benefit in almost all stratification groups. Again here, regardless of what we got in the pathology report. Overall survival also, in the second overall survival in interim analysis at the median follow-up of 8.4 years, it demonstrated an absolute overall survival benefit of 4.7% at 7 years over trastuzumab alone. And again, in all subgroups, it was shown to be beneficial. So again, one question that would your adjuvant treatment recommendation differ if these patients' HER2 status changed from HER2 positive to HER2 negative after neoadjuvant therapy? So the answer is no. It was seen that impact of HER2 status at surgery on Kadcyla efficacy, Kadcyla should not be withheld if the patients became HER2 negative in the residual disease at surgery.
Last 2 minutes, madam.
Yes, yes. So I'm coming to end. So presence of residual disease is the new decision point, and that is my last slide. So
Thank you, madam. Thank you, madam, for an excellent talk. Any question?
thank you very much.
Between subcutaneous and IV formulation, madam, how do you choose if cost is not a issue?
So cost is not an issue, and when we discuss with patients, many patients prefer subcutaneous because of main thing is the time. Second is convenience. When they go on to maintenance trastuzumab, pertuzumab combination, intravenous takes time. It requires an IV access, whereas subcutaneous Phesgo is much quicker. They don't have to take a day off here.
Yes, madam. Yeah.
Thank you.
Fine. Okay. Any more
So
questions?
we'll move forward, sir, for the
Yeah,
next talk.
okay. Thank you, madam. Thank you again.
Thank you very much.
Yeah.
Thank you.
Thank you, ma'am.
Thank you,
So
madam.
for the next talk, which is sponsored by AstraZeneca, I would like to invite Dr. Lokesh KN. The topic is redefining outcomes in 1L HER2 positive MBC with Enhertu pertuzumab. Over to you, sir, for your talk.
Okay, I will share the screen.
Sure, sir.
Allow me to share, no? Isn't allowing.
You can share it on.
Yeah. Okay, it's visible now?
Yes, sir, it's coming. Yes, sir, it's visible. Just make it full
Okay.
screen.
Okay.
Yeah, thank
Yeah.
you.
So good evening all. So I would like to thank AstraZeneca for giving me this opportunity to talk on redefining outcomes in first-line HER2 positive metastatic breast cancer with Enhertu and pertuzumab. It's a new combination. So long time we had no difference in any regimen for almost 1 decade. Now when the new drug has come into the first line, armamentarium. So let us discuss. These are my flow of contents. Okay, so first is the unmet need, then current treatment landscapes, then about Destiny Breast 09 study, its efficacy, safety, and then the dosing of Enhertu, and also the adverse events management, and finally the summary. So what is the unmet need in the management of HER2 positive metastatic breast cancer? This is how the treatment has evolved from 1995 to 2026, now almost more than 30 years. So initially it was the trastuzumab, then THP came in, then now in 2026, the Enhertu plus pertuzumab is emerged as a first line based on the Destiny Breast 09 study. So why we should have a very effective therapy in the first line rather than down the line? Because as you treat the patient down the lines, the almost 30% of the patient will not receive the second line treatment. Again, further down, almost 34%. So almost 64% of the patient will not be receiving the further 2 or 3 lines. So that's why we have to use the best effective drug combination in the first line to get a very good outcome or survival. So again, the patient with the de novo HER2 positive breast cancer, they all have a difference in outcome based on whether they present early or in the recurrent setting. So according to the sister register, the patient with de novo versus recurrent disease, we can make out that a patient with de novo will have more likely to have longer survival, less likely to have baseline CNS metastasis, and also more likely to have baseline bone or liver metastasis. And they are less likely to have hormone positive disease because most of them, they are all high grade. And again, when it comes to the progression-free survival, it's 17 in the de novo setting and only 11.9 months in the recurrent setting. So again, the de novo patients do well as compared to the recurrent HER2 positive breast cancer patients. So this is again the de novo patient with HER2 positive breast cancer. It's associated with improved survival and lower CNS metastasis burden. So with de novo, it was not reached the median survival, and again it was 44.5 months with the recurrent disease. Again, when it comes to the CNS metastasis, so majority of the patient will not have CNS metastasis at baseline, but eventually they are all going to develop the CNS metastasis and they are going to do bad. So again, the hormone receptor status, the hormone negative tumors typically demonstrate a worse prognosis compared to the hormone receptor positive tumors. Again, hormone negative, they are all higher histological grade, larger size, higher nodal involvement, and also they are all de novo metastatic breast cancer. So again, the visceral and brain metastases are prevalent in patients with HER2 positive metastatic breast cancer and associated with reduced survival. So these are all the things you see in patient with metastatic breast cancer with HER2 positive, the visceral metastasis. It involves the soft internal organs like liver, lung, and digestive organs. Around 47% of the patients, the patient present at first presentation with the HER2 positive metastatic breast cancer. Liver metastases are more common and with the poor survival, and also the risk factors for developing brain metastasis are all high for the patient already having a liver metastasis. Again, when it comes to the brain metastasis, the expected which is expected to occur around 25 to 30% of the patient associated with poor survival, and it can be considered a late event occurring 2 to 3 years following the initial diagnosis. So overall, the prevention of brain metastasis in this patient is highly important due to the detrimental effect on survival and also the quality of life. So there are these are several unmet needs in the positive metastatic breast cancer landscape. So since the approval of Cleopatra regime, the TCHP in 2012, there was no new first-line therapy. Then in the recurrent setting, again, the patient with metastatic breast cancer exhibit poorer outcomes with the visceral metastasis and brain metastasis are prevalent more often in HER2 positive breast cancer that compromise the survival and reduces the survival. And despite advancements, prevention and treatment of HER2 positive metastatic breast cancer with brain metastasis have been historically limited. Again, the HER2 negative, hormone receptor negative HER2 positive tumors demonstrate very poor prognosis. So what is the current treatment landscape for first-line metastatic breast cancer HER2 positive? So this is how the treatment has evolved. It was a THP, and there was no change in the first-line regime over a decade. Then survival was less than 50%, and again the patient more often developed CNS metastasis. So this Destiny Breast 09 marks a major advancement in the first-line HER2 positive metastatic breast cancer setting, addressing a long-standing unmet need. So based on this study, now NCCN 2026 fourth version recommend the Enhertu, that is famtrastuzumab deruxtecan plus pertuzumab as a category 2A regimen for patient with first-line HER2 positive metastatic breast cancer. So this is again the ESMO guidelines. You can see here even HER2 ER positive disease or ER negative disease. You can make out if a patient is suitable for chemotherapy. There is a choice of TDXT plus pertuzumab. Even in patient with ER negative disease also, there is a choice of TDXT plus pertuzumab for patient who are suitable for chemotherapy. So this is the Cleopatra study, which has established the median PFS of 18 months versus 12, and overall survival of 57 versus 48 months in first-line metastatic HER2-positive breast cancer. In the same patients with hormone-positive disease, again the addition of palbociclib plus hormonal therapy has shown that the median PFS of 44 months versus 29 months. So with a good hazard ratio of 0.75, which was statistically significant. So that's a PATINA study which was discussed earlier. And again, the HER2 CLIMB 05 study demonstrating the benefit of adding tucatinib to trastuzumab. Pertuzumab is showing a PFS benefit from 16 to 24 months without tucatinib. So this is the DESTINY-Breast09 study, which is redefining the outcomes in first-line HER2-positive metastatic breast cancer with Enhertu and pertuzumab. So this is the aim of the study, and this was already been discussed, all these things. So patients with brain metastasis were excluded from most of the other studies like Cleopatra study, and DESTINY-Breast09 may provide to support the use of TDXT in first line to improve the outcomes for patients with this HER2-positive breast cancer with brain metastasis. And again, it supports the potential prevention of brain metastasis with TDXT. So DESTINY-Breast09 will stratify the patient based on the prior treatment, whether it is de novo versus recurrent, hormone status positive versus negative, and whether it is PIK3 CF positive or negative. And again, sub-analysis may provide valuable data regarding TDXT use in patients with unmet needs in HER2-positive metastatic breast cancer. So this is the rationale of combining pertuzumab with trastuzumab. As we know, the pertuzumab, it's mainly it's a HER2 and HER2 heterodimerization it inhibits. The TDXT, it's mainly prevent the homodimerization. So both combining prevention of hetero and homodimerization inhibit the further down the line the PIK3 AKT mTOR pathway and further inhibition of cell proliferation and survival. So not only that, TDXT, again we know that it enters the cell internalization with cleavage and a release of payload, which causes apoptotic cell death, and again it diffuses through the cell membrane to the neighboring cell and causes what is called the bystander effect. This we have heard many a times in the TDXT talks. So what is DESTINY-Breast09 study? It's a global randomized open label phase 3 trial investigating the efficacy and safety of combination of Enhertu plus or minus pertuzumab versus the first line of choice, that is standard of care THP in the HER2-positive metastatic breast cancer. Again, inclusion criteria, it's all similar. Only the patient with adjuvant who are disease-free more than 6 months after neoadjuvant or adjuvant were included. One prior line of endocrine therapy for metastatic breast cancer was permitted, and there should be no other systemic treatment for the metastatic breast cancer. So with other exclusion criteria, and it's Enhertu plus pertuzumab 3 weekly versus the THP regimen. The primary endpoint was progression-free survival with key secondary endpoints of overall survival and also the response rates. So the first two arms results are updated. This is the interim analysis with the data cutoff at 26th February 2025. So it shows that there is a clinically meaningful and statistically significant median PFS. I'm sorry for the curve, which is observed with Enhertu and trastuzumab, pertuzumab with docetaxel. So it's 26.9 months versus 40 months. So very good hazard ratio of 0.56 with a 44% reduction in risk of disease progression or death. So and also the early positive trend in overall survival. Still the data is immature, but it's showing a very good benefit with respect to the progression-free survival. Again, the suppression of the curve, for the curve, the suppression between the PFS curves began at 6 months and increased at 12 and 24 months. So when it comes to the subgroup analysis, again, it has shown consistent benefit in all the different subgroups, whether it is de novo or recurrent disease and hormone status, PIK3 mutation, whether present or not, it has shown the benefit with respect to the brain metastasis. Again, a good benefit. Previous exposure to anti-HER2 therapies, previous exposure to pertuzumab, all the group of patients have a good benefit with the use of this combination of Enhertu plus pertuzumab. Again, with previous exposure to endocrine therapies, previous exposure to anthracycline, age at randomization, geographic region, baseline ECOG performance status, all shows that there is a good benefit with this combination over THP regime. So again, this combination demonstrated clinically meaningful improvement in PFS2 versus the THP regime. It was not reached with the Enhertu plus pertuzumab, and again it was 36 months with the THP regime. So that's about the efficacy. What about the safety? Again, with safety, when it comes to that, we clearly knows that what are the side effects of Enhertu and how we should prevent or monitor our index of suspicion, how to identify grade 1, grade 2, and when to stop. I think we have most of us know that what to do, how to do the dose reduction or modification for the same. So the dose modifications were used to help manage adverse reactions and keep patients on treatment with Enhertu plus pertuzumab. So treatment in the combination was continued until disease progression or unacceptable toxicity. The dose reduction was around 45%, dose interruption was around 68%, discontinuation was around 20%, but discontinuation was less as compared to the THP, which was 28.3%. And again, the median duration of treatment was higher with the combination of Enhertu plus pertuzumab, and the patient still receiving treatment at data cutoff was 45% for this combination versus 33% for the THP regime. So again, the adverse reaction, we know the two different set of reaction with Enhertu and pertuzumab versus THP. So again, the GIT side effects, the nausea, diarrhea, and again the myelosuppression. So all these are known, but it's less as compared to the THP arm, the myelosuppression. And apart from that, not much difference between the two arms when it comes to the grade 3 or 4 adverse events. Most important to remember, of course, is with Enhertu is the interstitial lung disease. The grade 1 around 4.5%, grade 2 was 7%. There was no grade 3 or 4. So 2 patients that was 0.5% had a grade 5. So any grade it is 12%, and only majority are grade 1 and 2. So we need to identify at grade 1 itself and stop the drug, and again we can re-challenge if it reverses within a month. If it is not reverses within a month to grade 0, I think we should always look for the guidelines whether should we stop the drug further. And again, when it comes to the decline in ventricular function, so it's around 11% overall, and most of them are grade 1 and grade 2. So again, the discontinuation, for whatever the reason, it's around 59% with Enhertu, and with other THP, it's 96% with the taxane and 66.6% with the trastuzumab. So what about the dosing and administration? So again, this is the one drug which has been included in the highly emetogenic potential. So we should always use a good antiemetics before planning Enhertu. So it should be administered sequentially. It's a white to yellow white lyophilized powder to concentrate for solution of infusion. It's available as 100 mg per vial. The dose is 5.4 mg IV, 90 minutes infusion first cycle. And next further it is same dose with the 30-minute infusion if it's well tolerated. It's given once in every 3 weeks until the disease progression. So we should always use a combination of antiemetics with 5-HT3 neurokinin receptor antagonist with dexamethasone, and even we can use olanzapine. So again, we have to manage the adverse events and require temporary interruption, reduction, or treatment discontinuation. So we have to look into the guidelines and plan. So if it needs dose reduction, the next step down dose is 4.4 mg per kg, then 3.2 mg per kg. Then further we cannot continue. It should be discontinued if patient is not tolerating. So again, the dose modification for adverse reaction, I will not go into all these things in detail. We can refer as and when required when the patient has adverse events of interstitial lung disease, neutropenia, febrile neutropenia, all this, we can check the guidelines as and when required. And again, the left ventricular ejection fraction decrease also we can see for any decline and look into the guidelines as and when required for the stop or dose reduction. So again, the adverse events management. So these are the adverse events: nausea and vomiting, fatigue, interstitial lung disease, diarrhea, alopecia, and hematological adverse events. So again, hematogenic potential, this I have already discussed. Combination of 4-drug regimen, neurokinin receptor antagonist, 5-HT3 antagonist, dexamethasone, olanzapine. And combination is better for the control of nausea and vomiting. Again, the fatigue, we have to first find out the cause of fatigue and treat the treatable causes. We should ask the patient to stay physically active, healthy, and with balanced diet, with good counseling and psychotherapy. And again, energy conservation methods and mind-body intervention. All these will benefit the patient to reduce the fatigue. And again, there are 5 S strategies to help minimize detection and management of interstitial lung disease: screen, scan, synergy, suspend treatment, and steroids. So all these things we should remember when you plan the patient on Enhertu for the detection and management of interstitial lung disease. Again, with respect to myelosuppression, anemia, neutropenia, and thrombocytopenia, it's all seen around 30 to 40% of the cases. To summarize the key takeaways, the persistent unmet needs remain in HER2-positive metastatic breast cancer, particularly in patients with recurrent disease, HER2-negative tumors, and brain metastasis, highlighting the need for more effective first-line therapies. The combination of Enhertu plus pertuzumab significantly improved PFS, reducing the risk of disease progression or death by 44% versus THP. Again, the clinical benefit was consistent across key patient subgroups, including those with recurrent disease, hormone-negative disease, and baseline brain metastasis. And again, the enhanced efficacy was achieved with a manageable and predictable safety profile, supporting Enhertu plus pertuzumab as a new first-line treatment option in HER2-positive metastatic breast cancer. Thank you.
Thank you, sir. Thank you so much.
Any questions?
Any questions? Yeah. So I don't think so, sir. There are any questions. So I would
Okay.
request you to proceed for the next talk, ESCO Updates 2026.
Yeah, okay. There is some minor change in the schedule. So I'll complete the ASCO lung update, followed by ASCO breast update by Dr. Vivek. So first, let me talk on ASCO lung updates. So first update is on advanced squamous cell carcinoma. My screen is visible?
Yes, sir. Screen is visible. You need to make it full screen, sir.
Okay. Okay. So the first update is on advanced squamous cell carcinoma. So long time the squamous cell we were limiting to paclitaxel, carboplatin, or gem-carbo. Then gradually the pembrolizumab has come in with or without chemotherapy based on PD-L1. Now we have something for squamous cell NSCLC. What is it? It is ivonescimab plus chemotherapy versus tislelizumab plus chemotherapy in previously untreated advanced squamous non-small cell lung cancer. It's a overall survival results of the phase 3 HARMONi-6 study. So these are the key takeaways. I will discuss that further. So before that, coming to the molecule, what is ivonescimab? It is nothing but it's a VEGF. Sorry, it's a VEGF, anti-VEGF and anti-PD-L1. It's a bispecific antibody with both anti-VEGF and also the 1 minute. Yeah. Sorry. Yes. Sorry. It's a bispecific antibody with anti-PDA1 and also the anti-VEGF activity. It's a combination of both the drug. Okay. So this is the background. advanced squamous NSCLC, it's a study comparing ivonescimab versus tislelizumab plus chemotherapy. So this is the study design. It's pathologically confirmed NSCLC 3B to 4 with no alterable gene options. They were randomized to paclitaxel versus tislelizumab versus paclitaxel versus ivonescimab. Ivonescimab dose was 20 mg per kg 3 weekly for 24 months. The hierarchical testing. This is the patient disposition. Most of the tumors are central type. We need to be very careful when we plan anti-VEGF therapy for a squamous cell, especially because they are all most of the time centrally placed, which may encases the blood vessel, which may cause us potential bleeding. So we need to be very careful in this study. They have used this drug. The central type was around 60% of the cases. They have some major vessel encasement around 16 to 18%, and with cavity around 9 to 8%. And again, some patient with history of hemoptysis around 30%. So it was used irrespective of the PDL1. This is the curve showing the significant survival difference. 27 versus 23 months with a significant p-value. Subgroup analysis again showing the benefit in all the subgroup, including the PDL1 less than 1. This is again with respect to the PDL1, whether it is less than 1 or more than 1, the benefit was seen. Again, more than 1 to 49 versus more than 50, again the benefit was seen. So again, when it comes to the safety, there is not much major difference. It's a manageable safety profile between the two arms. Again, when it comes to the adverse events, a bit different we may expect with ivonescimab. So the difference is, again, when it comes to the anti-VEGF molecule, the proteinuria, hemorrhage, hypertension, thromboembolism, and fistula, all these are known with the anti-VEGF therapy. I think around maybe around 10% of the cases have all these complications as compared to the tislelizumab. So that is the one we need to keep it in mind. So to conclude, the ivonescimab with chemotherapy significantly improved overall survival, 27 versus 23 months. And this all supports that this combination of ivonescimab with chemotherapy as a new standard of care for patient with advanced squamous NSCLC in China. So it's a Chinese molecule. It's a study was done in China. So we cannot maybe we cannot think of giving to all the other non-Chinese patients, but I don't think any reason it will not work in other non-Chinese patient. So actually the phase 3 global study is underway to find out really the benefit of this drug in non-Chinese population. So again, it is the same. So maybe this is the drug of choice for us in the near future for patient with squamous cell carcinoma. This was the publication in the Lancet. When it comes to the EGFR mutated NSCLC space, so we have a overall survival of first line amivantamab plus lazertinib in atypical EGFR mutated NSCLC. We know that atypical EGFR mutation, we usually tend to go for afatinib. So that was the only drug now we have shown benefit. Now we have a combination of amivantamab plus lazertinib shown some benefit in atypical EGFR mutated NSCLC. Again, I will not go into this in detail. To detect atypical EGFR mutation, we need to do NGS rather than going for RT-PCR or the FISH. So this is the combination. The amivantamab is again EGFR and MET inhibition. Lazertinib, adding to that, it causes a dual EGFR inhibition. So this is the study showing the good response rate of around 57% with the combination of amivantamab plus lazertinib. And again, the focus is on the secondary endpoint, that is the overall survival. So these are the subsequent therapies. This is the benefit in different group of patients. Again, the different mutations. So overall, the amivantamab lazertinib, the median overall survival was 41 months versus physician selected, it was 15 months. So it's very good now. Even the patient with atypical EGFR mutation, they are surviving for 41 months. So with this combination of amivantamab plus lazertinib, so it's actually very good. When it comes to the osimertinib plus chemotherapy in typical EGFR mutation, we have seen it's around 46 months. Now, even in atypical EGFR mutation, this combination has done well, reaching almost close to 46, that is 41 months. This is the safety with some difference in with a different set of side effects as it comes to amivantamab. Again, we all know the side effects: the paronychia, rash, diarrhea, stomatitis. So with the different with the good benefit, with a different set of side effects, that all we know how to manage with related to amivantamab. So to conclude, it's a single arm study of amivantamab plus lazertinib showing median OS of nearly 3.5 years. So that's actually very remarkable in patient with atypical EGFR mutated NSCLC. So now the ALK fusion. Again, this is the CROWN study. We all know it's a 7-year update. It's a 7-year update in lung cancer. It's actually unheard of. Usually 5 years we used to stop. Now 7-year update has come. That is something interesting when it comes to the patient with ALK positive NSCLC. Again, the lorlatinib, all you know that again the background, you know, at 5 years it has shown the 60 months median PFS. Again, the median survival was not reached. This is the study design. This all we know that this is the 5-year follow-up. At 60 months, it's 8% versus 60%. And this is at 7 years follow-up, 3 versus 55%. So that means even at 7 years, more than 50% of the patients are alive. So I don't know when we will reach the median survival. So after 5 years, we were thinking we may reach near future, but even after 7 years, we have not reached the median survival with the lorlatinib. It's at 7 years, it's 55%. Again, these are the different PFS events, subgroup analysis. You can clearly make out patient with brain metastasis are doing excellent when it comes to the use of lorlatinib. And intracranial progression, you can see the curve, it's kind of flattening. So it's very surprising to see the patient with brain metastasis, they are doing excellent with the patient on lorlatinib. Again, it's a sustained plateau in the intracranial progression that indicates a prolonged protective effect against the development of new brain metastasis and also the good sustained control. Adverse events, we all know what it is with respect to lorlatinib. We all know how to manage also. So I'll not go into that in detail. Again, there were no new emerging ALK resistant mutations were detected in the ctDNA samples collected at the end of lorlatinib treatment. Again, there are few early progressors and had a high number of alterations and high tumor mutation burden compared with the long-term responders. So to conclude, 7 years, 55% with the use of lorlatinib in first-line ALK positive NSCLC. So just 2 points I wanted to highlight. So I think even with the dose reduction, it has shown the benefit. 100 to 75, even 50 mg has shown the benefit. Maybe I think 50 mg is enough for all our patients to give in the first-line setting. We don't have study. I think it gives us a good thought for this. So we can think of doing some study of 50 mg versus 100 mg so that if it is really effective, we can really use 50 mg because always the 50 mg reduces the side effects of lorlatinib. So one more thing is patient who have oligoprogression, they were treated with radiation in the study. So I think the using one more form of treatment, that is radiation, may have some influence on the progression-free survival. But nevertheless, in spite of that, it has shown a very good, wonderful 7-year PFS of 55%. It's a wonderful drug for all our patients. So again, it is the same. This is a study published in Annals of Oncology. So again, when it comes to the non-metastatic setting, we are all doing EGFR and ALK for all our patients to use adjuvant TKIs. Now we have to start doing the RET fusion also. Why? Because this is the study, the Libretto 432 trial. It's a study of adjuvant selpercatinib in stage 1B to 3A, RET fusion positive NSCLC. It's a primary results. Again, selpercatinib, you know that it's a RET fusion targeted therapy for RET fusion positive NSCLC. So this is the background. This is the study design. It's a 1:1 design, selpercatinib versus placebo. The duration of selpercatinib is similar to what we use osimertinib. It's 3 years. So again, this was the question. 3 years is really needed, but we really don't know the answer. We may not get also because the red fusion itself is rare. But at present, we have only the study for using it for 3 years. This is the statistical patient disposition. This is the patient characteristics. I'm sorry for this, the curve. The benefit, I'll just go to the adverse events. It's all manageable with dose modification. Usually what we expect to see with any TKI. Some amount of QT prolongation was seen with selpercatinib. So we need to monitor the patient with ECG for QT prolongation. So the selpercatinib demonstrated statistically significant and clinically meaningful survival, event-free survival benefit in red fusion positive NSCLC. What is the benefit? The hazard ratio of 0.17. Look at the hazard ratio. It's wonderful, similar to what we have seen with osimertinib in some subgroup of patients. So it's look like a wonderful drug. We all should consider this as an adjuvant option for all patients with red fusion positive NSCLC. This was the publication in NEJM. So apart from that, there are 2 more studies I wanted to tell. Just a minute, give me 1 second. So one more study I wanted to highlight is this study. It's a Delphi 304 phase 3 trial. It's about post-hoc analysis of intracranial efficacy of tarlatamab versus chemotherapy as second-line treatment of SCLC. Of course, the tarlatamab is not available. The tarlatamab is not available. Again, it has shown the benefit in SCLC. The Delphi 304 trial, the tarlatamab has showed superior median overall survival, 13 versus 8 months, and the median PFS was 4.2 versus 3.7 versus chemotherapy for the patient who have progressed during or after platinum-based chemotherapy. Again, this is the reported survival benefit, the post-hoc analysis with intracranial efficacy. This is the study design. I will not go into that in detail. So I'll just go to the conclusion and say what is the benefit it has shown. So in patient with previously treated SCLC, the stable asymptomatic brain metastasis, the tarlatamab delayed the CNS progression and also the death, improved the intracranial efficacy. It's regardless of the presence of brain metastasis, it improved the overall survival. It was well tolerated, and actually it was better tolerated in patient with brain metastasis as compared to the chemotherapy. That is the one important thing I wanted to highlight. So again, tarlatamab, the expected side effects, the cytokine release syndrome, decreased appetite, and altered taste is all known. And investigator conclude that this combination, this drug, the tarlatamab, the post-hoc analysis support the use in the second-line setting, including those with brain metastasis. Apart from this, one more study is there. Just last study I wanted to show, that is for the patient with EGFR exon 20 insertion. So it's a Chinese drug, sunvozertinib versus platinum-based chemotherapy in advanced NSCLC with exon 20 EGFR insertion mutation. Sunvozertinib was already approved in the second line. This is a study in the first line setting. So we all know, again, the first line, that drug of choice is amivantamab plus chemotherapy. So this study has tried the sunvozertinib in the first line. This is the background. So patient with NSCLC non-squamous with EGFR exon 20 insertion. So we should do always the NGS for all lung cancer patient, because the NGS will pick up more exon 20 insertion mutations. If we do regular PCR, it will not detect a good number of EGFR exon 20 insertion. So NGS only will detect good number of exon 20 insertions. So we should always do the NGS. This is study is sunvozertinib 300 mg OD versus platinum-based chemotherapy until disease progression. This is the patient characteristics. This is showing the clear benefit of 10 months with the PFS versus 7.5 months. And again, the PFS subgroup, the benefit was seen in all the subgroups with good response rate of 68% versus 35. Again, median PFS 2 was also better. So again, these are the subsequent therapies. Treatment-related adverse events with leading to dose reduction or interruption are all known with any TKI. So these are same side effect expected with any TKI. The sunvozertinib is also the same. Again, the sunvozertinib shows significantly superior anti-tumor efficacy versus chemotherapy. In this setting, the median PFS 10.3 versus 7.5 with good disease control rate with manageable adverse events. So investigator conclude that this drug support the use of sunvozertinib as a single oral agent in the first-line treatment of NSCLC with EGFR exon 20 insertion. So that's all from my side. Any question we can discuss?
Thank you, sir. So, any questions are
Okay.
there?
Yeah.
Regarding lorlatinib, what percentage of the patients will have psychiatric adverse events, and how you will manage?
Psychiatric, I have not come across any of my patients what I have used for 2-3 patients. So it's I feel it's around 10 or 15%. So exact percentage I don't know. So, but it's all very well known. There are clear-cut guidelines for the management of the same.
Hallucination is one commonest one, but just wanted to check the recent update. Is there any difference in the dosage?
Yeah. So individual side effect I have not looked into. It has not much any changes in the 7-year update. So, but a good thing is that even with the dose reduction, they all have done similar. So I feel what we are using is actually the higher dose. Maybe 50 mg is enough. I feel so. So unless we do some study, it may not come in the guidelines. Maybe it's safe to use 50 mg if patient is not tolerating 100, or maybe if some financial burden, I don't know whether should we use.
Okay.
Thank you, sir. So, moving forward, I would like to invite Dr. Vivek for the ESCO updates 2026.
Breast cancer, yeah.
Breast cancer, yes. So, over to you, sir.
Yes, I'm sharing my screen.
Sure.
Yeah. Is my screen visible, sir?
Yes, sir.
Yeah, good evening, everyone. Before I begin, I would like to thank Dr. Lokesh, sir, my professor, for giving me this opportunity to present in this forum. So I'll be discussing on ASCO 2026 updates on breast cancer. So these are the trials that I'll cover. In the HER2 positive subgroup, the DESTINY-Breast07. In the hormone positive HER2 negative subgroup, the Persevera BC trial and the Victoria 1 study 2. In the triple negative subgroup, ASCENT-03 and the ASCENT-04 trial. So the first one is trastuzumab deruxtecan plus durvalumab in patients with previously untreated HER2 positive unresectable metastatic breast cancer. The final analysis from the DESTINY-Breast07. So this was a phase 1b/2 multi-center open label 2-part platform study. Here HER2 positive advanced metastatic breast cancer patients were taken with either with no brain metastasis or previously treated stable brain metastasis, and no prior therapy for advanced or metastatic breast cancer was allowed. An interval of more than 1 year from the adjuvant HER2 directed therapy was required. Here the patients were randomized into 3 modules, module 0, module 1 and module 2. In the module 0, it was TDXD monotherapy. In the module 1, it was TDXD plus durvalumab. Here the durvalumab was 1120 mg 3 weekly, and TDXD was the usual 5.4 mg per kg IV 3 weekly. And the module 2 was TDXD plus pertuzumab, the regimen used in the DESTINY-Breast09 study. So here the results for the module 1 were presented. The primary endpoint of this study was safety and tolerability. The secondary endpoints were overall response rate, progression-free survival, duration of response, PFS2, and overall survival. So this was the response to treatment as per RECIST 1.1. You can see that with TDXD monotherapy, the overall response rate was 78.7%, while with the combination of TDXD plus durvalumab, it was 82.8%. You can also see in the waterfall plot that the depth of response was good with both the regimens. This was the progression-free survival. Here, the two-year PFS rate was presented. With TDXD, it was 71.4%. With TDXD plus durvalumab, it was 75.5%. So a 4% improvement in PFS at 2 years was observed by the addition of durvalumab to TDXD. Coming to the safety overview, any grade adverse event of more than 3 was 57.3% in TDXD and 58.7% in the TDXD plus durvalumab arm. So there was no significant increase in grade 3 toxicities by the addition of durvalumab. Also, the other dreaded complication of TDXD is pneumonitis, just like how Lokesh was discussing. But here we see that more than equal to grade 3 was seen in 14.7% in the TDXD arm and 17.5% with the addition of durvalumab. So more than equal to 3 toxicity was not there at all in the TDXD arm and just 3.2% in the TDXD plus durvalumab arm. So the toxicity was similar when there was the addition of durvalumab with no other additional toxicity. So the key takeaway from this trial was this is the first report of TDXD plus durvalumab as first-line treatment for HER2-positive metastatic breast cancer. So it achieved a high ORR and durable responses. Also, activity was observed across all the patient subgroups. That is PD-L1 score of more than 1, more than 5%, and stromal tumor infiltrating lymphocytes level more than 10% were associated with numerically deeper and more durable responses in the exploratory analysis. So at 2 years, more than 75% of the patients remained progression-free. And also, safety profile was consistent with the known profile of each therapy. So in DESTINY-Breast07 trial, the first-line TDXD plus durvalumab demonstrated promising activity for the HER2-positive metastatic breast cancer patients and needs further evaluation as this is a phase 1b/2 trial. This is the first trial with the combination of an ADC and immunotherapy in the HER2-positive metastatic breast cancer setting. Now coming to the hormone-positive subgroup, this was regarding the SERD giredestrant. The trial was Persevera BC trial. Here, giredestrant plus palbociclib was compared with letrozole plus palbociclib as the first-line therapy in patients with estrogen receptor positive HER2 negative, locally advanced or metastatic breast cancer patient. So this was a phase 3 randomized double-blind placebo-controlled multi-center trial in the first-line locally advanced metastatic breast cancer patients. The eligibility criteria was hormone-positive HER2 negative patients, metastatic breast cancer patients, locally confirmed histologic or cytologic diagnosis, and no prior treatment for the advanced disease and no prior treatment with the SERD. 992 patients were taken in the study and randomized 1:1. The standard arm was the current standard of care, that is letrozole plus palbociclib, although the current standard is either ribociclib or abemaciclib, and the experimental arm was giredestrant plus palbociclib plus placebo. The treatment was continued until progressive disease or unacceptable toxicity. The primary endpoint was investigator-assessed PFS. The secondary endpoints were overall survival, overall response rate, clinical benefit rate, duration of response, safety, and patient-related outcomes. So coming to the primary endpoint, that is the investigator-assessed PFS, the median PFS in giredestrant plus palbociclib arm was 33 months, whereas it was 28 months in the letrozole plus palbociclib, with a hazard ratio of 0.89, but this was not statistically significant. So the giredestrant plus palbociclib demonstrated a numerical improvement in investigator-assessed PFS only, but it was not statistically significant. Since the benefit was same, they also looked on the adverse events. The adverse events were also similar between the two groups. Grade 3, grade 4 musculoskeletal pain was similar. Hepatotoxicity was 3.4% in the giredestrant arm and 5.7% in letrozole plus palbociclib arm. Giredestrant is known to have cardiac side effects. So there was grade 1 bradycardia was seen in 11.3% and grade 2 in 0.4%. So the key takeaway points and conclusions from this study was first-line giredestrant plus palbociclib resulted in only the numerical improvement in investigator-assessed PFS in the hormone-positive HER2 negative locally advanced metastatic breast cancer patients, though it did not meet the pre-specified statistical significance. This giredestrant combination was well tolerated with a manageable safety profile and no unexpected findings. Further exploration is needed to assess which subgroup of patients may benefit from giredestrant in the first-line setting. The second study in the hormone-positive group was Victoria 1 Study 2. This is a randomized open-label phase 3 study of gedatolisib plus fulvestrant with or without palbociclib versus standard of care in the hormone-positive, HER2-negative, PIK3 mutant advanced breast cancer patients. So currently in the PIK3 mutant subgroup of patients, alpelisib or inavolisib is combined with fulvestrant, which is the standard of care. So in this study, eligibility criteria were pre and postmenopausal men and women who had progression on or after CDK4/6 inhibitor plus non-steroidal aromatase inhibitor. So effectively second-line therapy for hormone-positive patients. And in this study 2, patients who had PIK3 mutation were considered. So they were divided into 3 groups with 3:3:1 randomization. The arm D included gedatolisib plus palbociclib plus fulvestrant. Arm E was alpelisib plus fulvestrant, which is the standard of care. And arm F included gedatolisib plus fulvestrant. The primary endpoint was PFS between the gedatolisib triplet, that is arm D versus the arm E. So this was the primary endpoint, the PFS. In the gedatolisib triplet, the median PFS was 11.1 month versus 5.6 months in the alpelisib plus fulvestrant arm. The hazard ratio of 0.5 and a significant p-value. In the gedatolisib doublet as well, we can see that the median PFS almost doubled from 5.6 months to 11.3 months, again with the hazard ratio of 0.51 and a significant p-value. The other key secondary endpoint was overall survival. So in the gedatolisib triplet arm, that is gedatolisib plus palbociclib plus fulvestrant, the median OS was not reached versus in the alpelisib group, it was 31 months. Hazard ratio was 0.76, but the data was still immature. So at this moment, it was not statistically significant. Coming to the safety and tolerability, we know that with alpelisib, hyperglycemia is the most common adverse events that we see. So any grade adverse event, 57% was there, and grade 3, 13% was there. But this was less in the gedatolisib arm, 15% hyperglycemia any grade, and only 2.6% of grade 3. However, since gedatolisib also has mTOR inhibition, neutropenia and stomatitis were more common in the gedatolisib arm. So the key takeaway points were gedatolisib plus fulvestrant with or without palbociclib doubled the median PFS compared to alpelisib plus fulvestrant in patients with hormone-positive, HER2-negative, PIK3 mutated advanced breast cancer. The treatment discontinuation of gedatolisib combination due to adverse events was very low, and the hyperglycemia rates was also very low. So Victoria 1 is the first phase 3 study to demonstrate that multi-target PAM inhibition, that is PIK3, AKT, and mTOR, triple pathway inhibition, significantly improves the outcomes for patients with PIK3CA mutant advanced breast cancer compared to inhibition of a single target of the pathway, like only PIK3 inhibition by using alpelisib. Now coming to the triple negative subgroup, 2 studies of sacituzumab govitecan, ASCENT-03 and 04 were discussed. And here efficacy by the biomarker subgroups were discussed. First one is ASCENT-03, where the biomarker subgroups with sacituzumab govitecan versus chemotherapy in participants with previously untreated advanced triple negative breast cancer patients who are not candidates for PD-L1 inhibitors. So in the introduction, we have seen that in the ASCENT-03, sacituzumab govitecan demonstrated significant and clinically meaningful improvement in PFS versus chemotherapy alone in participants with metastatic TNBC in the first line who are not candidates for PD-L1 inhibitor, either because the CPS score was less than 10 or they were ineligible for immune checkpoint inhibitor usage. We know that SG is a TROP-T directed ADC, and TROP-T overexpression is common in breast cancer. So it is seen that mutations in BRCA1 and BRCA2 genes as well as HER2 expression may affect the responsiveness to specific treatment used in MBC. So these were the biomarkers that may affect treatment selection. So in this study, these subgroups were analyzed. The first one is TROP2 expression. They were characterized by H score that is determined by the IHC. Scores were given as 0, 1, 2, and 3 depending on the intensity of staining of the TROP2. Then the tumor BRCA status was assessed. They were classified as either mutated or wild type, and HER2 expression was seen. classified as either HER2 0 or HER2 low, that is IHC 1 plus or 2 plus with FISH negative. So in the results part, the PFS by TROP2 H score quartiles were presented. We can see that the hazard ratio is favoring the sacituzumab govitecan irrespective of the H score quartiles. So PFS was longer with SG versus chemo across all the TROP2 H score quartile subgroups. Now coming to the PFS by tumor BRCA subgroups, here we can see that the curves for sacituzumab govitecan is better compared to chemotherapy, irrespective of whether the tumor BRCA was wild type or mutated. Now coming to the PFS by the HER2 subgroups, here again we can see that the Kaplan-Meier curves are showing that the curves for sacituzumab govitecan was better than chemo, irrespective of whether the HER2 IHC was 0 or HER2 was low expression. So the key takeaway points from this ASCENT-03 biomarker analysis was that the median PFS was longer with Sasi-Govi versus chemo across all TROP2 expression, tumor BRCA mutation, and HER2 expression subgroups, consistent with the primary analysis of ASCENT-03. So these results reinforce a significant clinically meaningful benefit of SG as first-line treatment for advanced TNBC patients who are not candidates for PD-L1 inhibitors across the biomarker subgroups. The last study was ASCENT-04. This was a similar efficacy by biomarker subgroups in the PD-L1 positive metastatic triple negative breast cancer patients. So in the ASCENT-04 study, it demonstrated significant clinically meaningful improvement in PFS with SG plus Pembro versus chemo plus pembrolizumab in participants with previously untreated PD-L1 positive advanced triple negative breast cancer. Here again, these three biomarkers were studied. The first one was the TROP2 H score quartiles. Here also we can see that in the forest plot that irrespective of the TROP2 H score quartiles, the SG plus Pembro group did better than the chemo plus Pembro group. Here again, the PFS in the tumor BRCA wild status patients in the median PFS was 9.6 months in the SG plus Pembro group, whereas it was 7.4 months in the chemo plus Pembro group. And in the BRCA mutated patients as well, the median PFS was 16 months in SG plus Pembro versus 12 months in chemo plus Pembro group. Again, by subgroups of the HER2, we can see that the SG plus Pembro did better irrespective of HER2 low or HER2 0. So irrespective of the TROP2 expression, BRCA expression or HER2 mutation, SG plus Pembro did better. So in summary, DESTINY-Breast07, first trial of ADC plus immunotherapy in HER2 positive metastatic breast cancer, but this was just a phase 1b/2 dose expansion study, so probably needs phase 3 trials. In the Persevera study, we saw that only numerical increase of PFS was there. So standard of care is still mostly NSAI plus CDK4/6 inhibitor. In the Victoria-1 study, here this may be one of the practice-changing studies for PIK3 mutated patients. Geratolizumab plus fulvestrant doubled the PFS from 5.6 months to 11 months. The OS is still immature. In ASCENT-03 and 04, we saw that irrespective of the biomarkers expression, sacituzumab govitecan did better compared to the comparator arm. Thank you, everyone.
Thank you, Vivek, for a wonderful discussion. What do you think is the practice changing among all these studies from tomorrow for us?
Sir, geratolizumab, but the drug is, I don't think it is still available, sir. If it becomes available, we can do that, sir.
Once it is available, definitely geratolizumab.
We can use that for PIK3 mutated patients, sir, because the PFS was doubled. And sacituzumab govitecan also. If the finances are not an issue, we can use that in the first line settings.
Yeah, now SG is coming to the first line, irrespective of PDL1, more than PDL1, 10 or less than 10. It's a combination for more than 10, less than 10 single agent. Apart from that, I think there is one keynote 522 update, that is pembrolizumab, neoadjuvant and adjuvant. 8 years data, it's showing 7% benefit. So I think it's very excellent. We argue for 1 or 2% benefit in adjuvant or neoadjuvant setting. Now it has shown 8% benefit in 7 years. Keynote 522 Pembro. I think that is also give good confidence for us. Okay, fine. Thank you, Vivek. Thank you very much.
Thank you.
Thank you. So we'll move on to the next session, sponsored by Novartis. The moderator, it's a panel discussion. Moderator is Dr. Karthik Udupa, professor from Manipal University. So over to Dr. Karthik for panel discussion.
Yeah, thank you, Dr. Lokesh. Thank you for inviting. And this session is sponsored by Novartis. Try to share the slides. Yeah, is my slide visible and am I audible?
Yes, sir.
Okay, so I have three wonderful panelists with me. Dr. Satish CT, a well-known figure from Bangalore, consultant from HCG Bangalore. Dr. Rachan Shetty, who's my colleague from Mangalore. He's practicing at AJ Hospital. And Dr. Arun Barad, he's practicing at ESI Hospital, Gulbarga. So welcome to all my panelists. So let's start the panel discussion. We have around 40 minutes with us. So I'll be mainly focusing here regarding the NATALEE trial and the role of adjuvant ribociclib in the early breast cancer scenario. So if we see the evolution of endocrine-based adjuvant treatment for hormone-positive HER2-negative breast cancer, way back in 1996-97, US approval for anastrozole and letrozole came in the adjuvant setting, followed by in 2021, exemestane was approved in adjuvant setting. Then there were a lot of trials for extended aromatase inhibitors or endocrine therapies, Atlas MA17R, where it showed that an NSBP B42, where around 10 years of aromatase inhibitors was beneficial in high-risk population. Coming to CDK usage in the adjuvant therapy, the first trial which got approval was abemaciclib trial, that is Monarch E, where for the high-risk early breast cancer, abemaciclib showed a significant IDFS benefit. Then there were a few negative trials, PALAS and Finolop. So when everybody started thinking that CDK is a wonder drug, the palbociclib failed to show overall survival in the early breast cancer scenario, even though it had shown significant benefit in the metastatic setting. And in 2024, we based on NATALEE trial, ribociclib and our NSAI got the approval. And right now, this is a category 1 recommendation in NCCN and ESMO. So this picture, actually, this figure sums up everything regarding the hormone positive and the hormone negative scenario. Hormone negative, triple negative breast cancer. If somebody asks me which is the best subset you want to treat, maybe I will tell right now that early breast cancer hormone negative, because we will know the results in 5 years or 6 years time, whether the patient will live longer or whether the patient will recur back. Because in 5 to 6 years, if the patient doesn't have a recurrence, usually the patient will not have recurrence. This is what is depicted, but it is it's not it is not so in the hormone positive subset. We see lot of recurrences even beyond 10 years. This is like a test match cricket. Even on day 4, day 5, the wickets will be falling. If the set batsman will actually get out. So this is how it is. And even at the end of say 15 years to 20 years, we can see few recurrences. So hormone positive and hormone negative, the scenarios are a little different. Hormone negative, or rather I can tell hormone negative and HER2 positive scenario, the recurrences do not happen late in the course of the treatment, but in the hormone positive setting, the recurrences do happen even beyond 5 to 10 years. So I'm going to discuss about these three patients. The first patient is a dentist. Remember about these patients because these photos will come again and again in my presentation. So panelists, be attentive. So this first patient is a Meera. She's a dentist who was operated for CA breast. It's a PT2N2 disease, luminal A, grade 2, around 5 centimeter tumor. She is postmenopausal. She has undergone total mastectomy, axillary lymph node dissection without immediate reconstruction, completed radiotherapy and chemotherapy, and started endocrine therapy 1 month back. So this is a PT2N2, hormone positive, and K67 is 11%. So maybe I start with Dr. Satish. Dr. Satish, what would you estimate Mira's risk to be of any recurrence within the first 5 years of starting of adjuvant treatment? That is, if we start on only aromatase inhibitor.
It is a classical high risk case, N2 disease. It is eligible for both the studies. Definitely is having a more risk actually here. That is, I can say that is almost a 30% risk is there.
Dr. Rachan, do you agree with this?
Yeah,
So around
it's a high
30%
risk,
risk.
not N2 disease. So I think offhand to tell what is the risk of recurrence is difficult. We use the predict scoring to say what is the risk of recurrence and make decision. But N2 disease, stage 3, I mean, even though hormone
The
positive,
patient
they
is
have,
on only aromatase inhibitor.
yeah, but she still it would be higher than 15-20%.
Dr. Aran, I will pose the next patient to you. So she is Garima, 29-year-old graphic designer.
Karthik, just numerically, it may be like studies, global data, all the things are because individually, if we go, that is definitely is a high risk case.
Correct.
Like it's N2DC is like T2 rather than T2, that N2 is the main thing that like more than 4 lymph nodes are there, 4 lymph nodes, very high risk of recurrence will be there. Definitely that chemo, radiation, all the things will do it, but hormone therapy is not sufficient at all with this today's
Yeah,
practice.
absolutely right. I mean, hormone therapy is not right and definitely requires addition of CDK inhibitor. But what may be the benefit if we don't, or if we don't give CDK inhibitor? What is the extra risk the patient has to encounter was the question. So maybe I think it is as the patient is high risk, you told around 30%, and Dr. Rachan told maybe 15 to 20%. Okay, so the second patient is Garima, who's a 29-year-old graphic designer. Again, patient was diagnosed with CA breast. This is a little different. She's T2N1 early breast cancer, premenopausal lady. So around 3.5 centimeter tumor, grade 2 K67, again 17%. ERPR strongly positive. She underwent a breast conservation surgery, completed radio and chemotherapy, and yet to start on endocrine therapy. But because she was premenopausal, was started on Goserelin. So this is T2N1. Dr. Arun, what may be the benefit of adding a CDK inhibitor in this lady?
Sir, here we can see that she is positive.
Dr. Arun, I didn't get the answer.
N1 disease. It is 17%.
17%. Okay, fine.
Yes, sir. Ki67 is 17%.
Correct.
So I think she'll benefit with CDK4 addition, inhibitors addition.
Yes.
And regarding the risk of recurrence, which goes, so I'll put it around probably around 10 to 15%.
So these are all arbitrary figure. I mean, there is no clear-cut risk with, as Dr. Satish and Dr. Rachan told, we need to probably put it in predict and see what is the exact risk. But around 15 to 20, 10 to 15% is a fair call. So this is the third patient who is Jaya, 67-year-old postmenopausal T2N0. But this lady had high genomic risk. The size of the tumor was 3.4 centimeter. Grade 2 K67 was high, 37%. So T2N0 high genomic risk with the high Ka67. Again, Dr. Satish, this lady, how do you think she will do with only aromatase inhibitor? So what may be the risk if you don't give a CDK inhibitor in the adjuvant setting?
See, this is a luminal B, K67 is high, even though it's node negative. See, many times, like many of us, everyone is to practice only node positive is only that a high risk. It means like the recurrence chance will be high. Yes, data is there, and even if you go the data in if you go in-depth analysis of the node negative also high risk category, still by addition of CDK4 inhibitor with the Natali data, it says that its benefit is almost similar to like node positive cases. This like definitely that we should explore actually that risk is like definitely is there. numerically it may be difference. Actually, it will be around 10 to 15, around 15 to 20% will be there in this case also. We cannot ignore node negative also. It is a high risk case because of the luminal B, the case 67 is high.
So, Dr. Achan, do you agree with Dr. Satish's answer, or do you want to give a little different figure here?
Yeah, I agree with this answer.
So maybe I think node positive and high risk node negative N1, the risk of relapse is almost similar. That's what the panelists are saying. So they're absolutely right. So if I have to justify their answers, I have three studies. One from one Pan et al., Javri et al., and Fashing et al. So this is a study from Pan. This was about a pooled randomized control trial analysis showed improvement in the risk of relapse over last 20 years, but significant risk for ER positive patients persist. So in this, there are two diagrams, left hand side and right hand side. So this was a little left hand is little, the analysis was between 1976 to 2011. So if you see the nodal status as it increases from N0 to N1 and N2, the relapse rates also do increase. So if you have to just tell that around 10-year relapses for N0 was around 11%, it was around 19% for N1, and it was 36% for N2 at 10 years. So if you think that the things have all changed in last 10 years, you can see in the right hand side that the relapse rates are almost similar. It is 7.5, 15.2 and 29.5, marginally better, but the relapses do happen. And as I told in my previous diagram, the relapses goes on increasing as the years pass by. There is no the curve doesn't become plateaued. It's still on the rise, and in the ER positive scenario, this is the problem. The chance of relapse doesn't really settle down. As the years goes by, there will be chance of relapse. The chance of relapse actually doesn't plateau. So this is definitely with the N1, N2, and N3 diseases, the risk of relapses do increase, and the things have not changed much in the last 10 years. So this is what Dr. Satish was telling, N1 and N0 high risk. So what are the high risk N0s? If the patient has a T3 disease, grade 3 disease, Ki67, high Ki67, then they behave something differently than the N0 category, and the risk of relapse, risk of overall relapse is around 2.9 times greater than the N0 low risk, and 4.4 times greater. Distant relapses are around 4.4 times greater than the N0 low risk. So if you see the right hand side diagram, the one with the break one, that is red break, and the brown break break lines are actually N0 disease CA breast, and you can see that the blue and the red dot goes hand in hand, that is N0 and the N0 non-high risk go hand in hand, and the yellow and the brown dot goes hand in hand. That basically tells that the N0 high risk and the N1, the risk of relapses are almost similar. Okay, so this is what Dr. Satish was talking about. So N0, you can't ignore N0 high risk, especially the one which was included in Natalie. It is almost similar that it behaves as though it is a N1 disease. So if we see the risk of relapses across the Natalie population, so we know that these are the high risk patients. So 1 in 8 patients in the Natalie population do relapse at 3 years, and 1 in 5 patients do relapse by 5 years. And 90% of the relapses are distant relapses. That's why we have to be careful. It is not the local relapses, it is the distant relapses what happens. So it is always better to treat them with probably a high intensity protocol rather than just giving a aromatase inhibitor. So I will pose this question to Dr. Satish. How has your experience been with the ribociclib in the advanced breast cancer setting?
Yeah, see, we use many cases. Like first, everyone is very happy with the palbociclib. That is the first summer actually. Then later, like ribociclib is come. Definitely, we have a good experience with advanced breast cancer. But only thing is that first 2-3 months following is very important. That like the dose reductions will most likely will come in the first 4 months only. Later, I'm not telling it doesn't happen. The scenario can change. Like we should properly monitor them. Then once a patient is the dose like is adjusted, then definitely become easy for them. That is seen. And have a good experience with the lung. There are patients are still now even they're taking more than beyond 5 years also. The patients are advanced cancer.
So, I mean, if I have to probably ask you a little differently, so if you want to grade these three CDK inhibitors, so your first preference or your most of your patients are rather on palbociclib, followed by ribo and followed by abema.
No. We are not. No, it's like when first beginning the drug introduced to the as all about the drug, we started using the palbo. Many
Correct.
patients use palbociclib, and later then ribociclib has come in the picture. Actually, we started using ribociclib also. Then later that abemaciclib is the one next last molecule to introduce. Actually, people are worried about even diarrhea and the thing. We use that criteria as a second line high risk cases. Actually, we started using actually. There also we got a good patients are there. Especially we used to select actually for the abema very high risk cases only we try to use it. Because by that time we are very comfortable with this molecule Falbo and ribociclib because comfortably you're using this molecule for a median number of years actually. But the ribociclib, we know that advanced cancer, we have a first line data. Previously, we are all three molecule, we didn't have a OS data beginning. We are everywhere, we are happy with all PFS data with all the three molecules. We are used to do interchange because the cost is a factor. Palbociclib, we even used to get the drug molecule, even people card holder also. That people used to use it, all the thing that's what we are very comfortable and we used to use it. And later this drug also we had even trial in HCG that ribociclib first line treatment also we had good number of recruitment as we did actually myself and Dr. Shekhar sir. And later Abema also we had a study, phase 4 study also we had, and even clinical level started using actually. We got all the molecules have used. But if you use that now ribociclib OS data has come, that is like not only PFS, OS data also has come. We started like more of inclining towards ribociclib we are using more actually compared to the other molecule. We are
What
using
about
many of
the
yeah.
toxicity profile with ribociclib, Dr. Satish? Is it like how many of your patients do you dose? I mean, you have to reduce the dose. I think that you will start with 600 mg for all the patients.
600
but
mg most of the time we'll use it unless a very patient is like borderline fragile elderly people. We may use a 400 something rarely. Advanced cancer, many of our patients are started with a 600. But almost I can say that 40% of the patients require a dose modification, like for 600 to 400 like is done. Some patient even 200 also we are done. Now we started even adjuvant setting. So every patient is very comfortable with the 400 mg. That very easy to tolerate all the things what we are seeing compared to advanced cancer. But data is there. We have to use it for 600 mg. We are still now also like we start using when you're starting 600 mg, we use it. Early cancer, early EBC will use a 400 mg. And EBC, we are not done. Only one patient we have reduction of the dose in the young patient only that 200 mg. All the patient has almost many of the patients are everyone is comfortable with 400 mg in EBC. But advanced cancer can say up to 40% you may require a dose reduction. Comfortable actually to use it.
Dr. Achan, how would you compare it with other CDK inhibitors in advanced breast cancer, say with the Palbo and Abema?
I think ribociclib is also approved in visceral crisis, hormonal therapy plus ribociclib. So I think it is significantly better. So earlier we used to give chemo for in visceral crisis. Now we can use ribociclib plus aromatase inhibitor along with the GnRH analog. I think Spalbo was not, it doesn't work in that setting.
So do you still use Palbo in any of your patients with metastatic CA breast, or your first line choice is always ribociclib?
No, most of the patients are on palbociclib because of cost reasons.
No,
but I guess
take apart the cost, like your preference, if you have to tell.
Ribo or abemaciclib, and Ribo is better than abemaciclib considering side effect profile. GI side effects of abemaciclib is significant. So again, in adjuvant setting, wider patients are included compared to abemaciclib.
Dr. Arun, your take on other CDK inhibitors compared to Ribo?
Yes, sir. Sir, good evening. Just frankly speaking, I am a surgical oncologist, sir. So I have very minimal experience doing this. So usually refer to medical oncologist. So yes, few patients I have seen that those who use Rebo, they had a very good in advanced breast cancer setting. They had good improvement as well. So my experience is limited, sir. Sorry.
Just because you're a surgical oncologist, I want to pose a question. Have you used any of your patients who are little elderly? Have you used
Yes.
neoadjuvant hormonal therapy followed by surgery? If the say the patient is not fit for chemotherapy.
Yes, sir.
And the
Yes.
second question is, have you used any patients neoadjuvant hormone plus CDK inhibitors? Then you have operated.
Sir, we have not used both hormonal therapy and CDK as a neoadjuvant setting. But yes, there was one patient very recently, 75-year-old with lot of comorbidities. He had cardiac comorbidities as well. In that particular patient, we had used neoadjuvant hormonal therapy and then proceeded with the surgery in under local anesthesia, sir.
Yes. So this is what our panelists were talking about. So in the advanced breast cancer setting, NCCN, ESMO, MCBS, and ABC 6 and 7 guidelines recommends ribociclib as the best CDK inhibitor to be used with aromatase inhibitors in the setting of a metastatic disease. So coming to ribociclib, now approved for a broad range of patients. This is about the adjuvant. So we know that in the NATALEE, these were the patients who were included, any patients with high risk N0, T2, N0 with the high risk features grade 3 or grade 2 with high risk features with the high Ki67 or more than 20% Ki67 or high genomic risk. If the patient is T3, T4 node positive patients were all included, but in the NATALEE, the selection was little different. And NCCN and ESMO right now has come out with the recent guidelines says that it's a category 1 recommendation, and ESMO says that ribociclib is rated A in the curative setting. So both have rated very high in the adjuvant setting as well, whenever it is recommended or whenever it is indicated. So in the NATALEE, in the monarchy, the N0 patients were not included at all. Only in N1 also, only the grade 3 and or the patients with the tumor of more than 5 centimeters were included. One interesting thing was time window to add CDK4/6 inhibitor after starting endocrine therapy was up to 12 months, which is actually a boon because the patient can think about adding or starting CDK inhibitors. They have 12 months window before we take a call whether to start or not. But in Abhima, it was only 3 months. So, Dr. Satish, what is your take on guidelines-based treatment decision making, making in advanced breast cancer and early breast cancer scenario? And what do you say about this window actually? 1 year window and the 3 months window for Abhima and 1 year window for ribociclib.
See, metastatic disease, we are all convinced to use the drug, any one of the CDK inhibitor, because patients are symptomatic, like patient like okay, any drug is there, like whether Abhima or like a ribociclib, some kind of fatigue, drug count variation, blood count variations will be there. This follow-up monitoring all the things, like they'll accept it. Okay, your disease there in the body, monitoring the disease with the scans, all the things, they'll be accepting. But when they're treating the cure treatment, you're done only hormone therapy. People, they want to get rid of all the thing. Okay, just you want a one follow up actually without any side effect. See that the only thing is there, many of us will jump it. Once we finish up treatment, we want to jump add a CDK4 inhibitor. But we have to understand that one patient should be free from the previous treatment's toxicity. Patient is fatigue, tiredness, like a post-radiation reactions, all the things should be like, yeah, generally like people will jump like maybe 3 to 4 weeks or maybe within 1.5 months, we want to start CDK4 inhibitor. The window period gives the opportunity to like the patient to get recovery of the side effect all the thing. But problem is once the moment they start the CDK4 inhibitor, they'll accept it or not. That's the one thing. But we have to proper counseling all the things we're supposed to do it all the thing. One advantage of ribociclib is there even window of opportunity that even like you're not started immediately. Have the patient may not be ready in the first counseling, second counseling. At least you have opportunity to okay, you can add up actually even subsequent follow up at least that the patient will be ready to accept actually. That is one of the opportunity, and also the guidelines say that clear cut. You pointed out actually where you have to use the ribociclib and Abima, the risk, like which are the cases you have to add actually. I don't want to repeat all the thing. I think that's very clear cut. This gives a more opportunity to add even the patient. Many patients may not be willing to go for the immediate CDK4 because suddenly I come out of a surgery, chemotherapy, radiation. They may not be accepting actually. That is one of the
You
what
have
we see
time to
that.
counsel them
Yeah,
maybe once or
counseling
twice.
them like the one counseling may not be adequate actually. Maybe 2-3 counseling, maybe follow-up period. It will give the opportunity to make them counseling to add on the adjuvant CDK4. That is the one advantage of we are having the 12 months period with the ribociclib. Okay.
The point well taken, and this is a very important point where the physicians will have some time to counsel the patients regarding adjuvant therapy, and for Ribo gives us a window of 12 months. So this is, I think, with the for the want of time, I will just go rush through my next few slides. So this is a T2N2, our dentist. So we all have discussed regarding this. The only thing what I want to ask Rachan is, this is a lady T2N0, T2N2. So we have an option of adding Abima or Ribo. So she's pretty, I mean, fit dentist. She knows about the toxicities. What will be your preference, Rachan?
With the data, ribociclib.
Okay. So why not
Even
Abima?
both can be used. Both can be used, but I would prefer. Since ribociclib data looks a little stronger, and abemaciclib, whatever little patients have used, have found GI toxicity to be difficult.
Okay. Yes. Agreed. So the second patient, that is T2N1.
Karthik, just I want to ask. See that Abima have a longer data. The one drawback of Abima is there, like, okay, you have seen the first like 3 years, 5 years, 7-year follow-up. Actually, you see the consistent graphs are like consistent maintaining, and even the absolute benefit also is you're seeing the increasing. Natalie data was not there, like 5 years, like recently published. Actually, that is giving it is giving the confidence you can use it. The number of years of follow-up we can try to do. Only advantage of Abima is the longer follow-up is it. That's what. Problem if you are like convincing the patient, okay, both the things are going to work. Actually, one is likely have a longer data than the ribociclib. But one thing is there like toxicity. You see, like Abima, like you have to start with 150, but this Ribo to 400 mg easily you can, because everyone is already started experiencing actually. Easy to start with the 400 mg. That toxicity is the very, very comfortable with the 400 mg. I think all our patients. That's the one advantage. Okay. Yeah.
So I think patient 2 and 3, we are convinced that CDK has to be added, and we don't have Abima is not recommended in N1 disease, where this grade was 2 for the premenopausal lady, and this is the third patient who is postmenopausal T2N0, again high risk patient. So again we don't have a data, or we don't have a data for adding Abima. Again, these two patients, there is by default will receive aromatase inhibitors with the ribociclib. For the second patient, maybe we'll add a OFS also. So this is a Natalie study. I will not go into the depth of this. We know the selected patients. Who are the patients who are selected? The patients were given ribociclib for 3 years. The dose of ribociclib 400 mg, 3 out of 4 weeks. This is what Dr. Satish was talking about. The 3 years treatment duration narrative, the longer duration to extend time on target exposure. We know that these 3 to 5 years are very crucial. A lot of patients do relapse at this point of time. So longer duration to extend the time on target exposure and prevent early and late relapses. Better safety profile with 400 mg versus 600 mg, low incidence of symptomatic adverse effects, and a median time of discontinuation of 4 months. Third is, we always do, according to the ESMO data, we need to call these patients every 3 months for first 3 years. So Ribo 3-year schedule fits into the ESMO guidelines follow-up recommendations. So you can follow them up. If once the patients are comfortable, 3 monthly, you can call them for the first 3 years. Then you stop Ribo and start calling them once in 6 months. And adjustable dose without new prescription, limiting the wastage and extra visits. So Abima is one of the problem with most of the patients. We need to counsel them again and again for first 6 months to 8 months, where they can have a lot of toxicity. So these are the advantages on the basis of the evidence shared with the, what is your take on the 3-year treatment duration, Dr. Rachan? So are you convinced about this 3-year duration, or say the Abhima is only for 2 years? So are you more comfortable convincing the patients for 2 years versus 3 years? Dr. Rachan, are you there?
Yeah, I'm there. I mean, 2 years is also not very shorter time.
Short.
The second, yeah. So 2 years is also not a shorter time. Once they start taking, I don't think there should be any difference.
So I think you are more convinced or more comfortable counseling for Abhima for 3 years rather than ribociclib for 3 years rather than Abhima for 2 years.
2 years. I mean, longer is, I think, psychologically better. In my case, I mean, data is also now it is saying this. Initially, they said Abema is better than others. Now say ribociclib is better than abemaciclib.
Yeah, Dr. Arun, do you agree with this?
Yes, sir. I agree with sir, Dr. Rachan, sir.
Last 5 minutes, Karthik.
Yeah. Just so this is IDFS data of the Natalie, where there is a different progression. Invasive disease-free survival was 85.5 versus 81% with the with the NSAI, that is aromatase inhibitors alone. Clear cut around 4.5% benefit was there, which with the hazard ratio of 0.176 and which attributes to 28.4% relative risk reduction. If you see the subgroup analysis, almost all the patients have benefited with addition of ribociclib in the Natalie, say premenopausal versus postmenopausal, prior chemotherapy, yes or no, prior endocrine therapy, where we were talking about the window of 1 year. AJCC stage 2 and 3 nodal, you can see that N0 actually has, in fact, it has done really well, or the benefit is excellent with the addition of ribociclib. K67 less than or more than 20%. All these subgroup actually have got benefited with addition of ribociclib. So if you see the distant recurrent free survival also, it is, you know that the distant recurrent free survival are more with the aromatase inhibitors alone compared to ribociclib with the aromatase inhibitors. It was 11.4% versus 8.1%. So if you take stage 2 and stage 3, we always think that the stage 2 patients are, whether we to start or not. Stage 3, definitely the node positive patients will get benefited, but there was a significant benefit of adding ribo in stage 2, 3.7% benefit in IDFS, and stage 3 it was 5.6%. N0 and N node positive. N0, the high risk N0, the benefit was 5.7% versus 4.4% in N1 to N3 disease. So definitely there was a definite benefit in high risk N0 patient with the addition of ribociclib. So this is what we were talking about. Definitely in stage 3 and in node positive patients, there was a benefit of adding ribociclib to the aromatase inhibitor, understandably. But in those patients who were N0 high risk, also around 5.7% absolute risk reduction was there. And this is one particular subset we should not ignore about N0 high risk. Definitely counsel the patients for adding ribociclib for 3 years. So maybe this is my last set of question on the basis of evidence shared with what is your take on ribociclib as suitable for adjuvant treatment to reduce the risk of recurrence. Maybe I will start with Dr. Satish and then come to Dr. Rachan. Are you convinced with the data, Dr. Satish?
Yeah, definitely I convinced actually.
So N0, are you convinced with the data, high risk N0?
Yes. Yeah.
So it has probably become our routine practice to counsel for addition of ribociclib, right?
Yes. Definitely I try to convince that this irrespective of the nodal state of high risk is there. High risk node N0 disease or N1 positive, any N node positive, definitely I'll go with the CDK4. That ribo is the data. That N2 also, that I don't know, that you asked that 3 years easy life, 2 years tough
Correct.
life is there, but that is almost
Yes.
2/3 of people they require dose reduction tough time. Even though 2 years you say that, but it's a tough time with the Abhima. That's the one thing.
Points well taken. Dr. Rachan, what is your take? N0 high risk, are you convinced?
N0 high risk, yeah, I mean, if it is genomic high risk, or then I would use adjuvant therapy, ribociclib. But then again, we have to discuss with the patient. Are they willing to take?
Dr. Arun, do you agree with, or do you
Yes, sir.
yes,
Yes, sir.
are you
With
convinced with the
available
data?
yes, sir. With the current data, I definitely agree with this, sir.
So I think that we all know about the risk or the side effects of ribociclib. So you can see here that the grade 3 side effects were much lesser. Grade 1 and 2 or more, say arthralgia, nausea, headache, hot flashes. The major problem was with the AST/ALT elevation. So we have to probably keep doing the LFTs monthly for a couple of months, or once in for first 3 months. Then once after 3 months, we can do once in 2 weeks, 2 months. So if this was a survey which was conducted among the females in US, where they actually where they were asked what are the 3 best benefit they could get from ribociclib compared to Abima, and the survey told that actually the treatment efficacy, lower risk of diarrhea, and lower fatigue were ranked first 3 among the survey. And QOL was maintained with the ribociclib, addition of ribociclib versus aromatase inhibitors alone, or rather endocrine therapy alone. So in summary, in patients with the hormone positive, HER2 negative early breast cancer, ribociclib with NSAI versus NSAI non-steroidal aromatase inhibitors alone, it reduces the risk of recurrence, including risk of distant recurrences. At 4 years, the relative risk of reduction of invasive disease was around 28.5%, suitable for a broad range of eligible patients, including those with N+ and high risk N0 diseases, demonstrated a manageable and mostly reversible safety profile, and it maintained the health related quality of life. So with this, Dr. Satish and Dr. Rachan, Dr. Arun, I think we have around 1 minute. Can you quickly give your final comments? Dr. Satish?
Yeah. Hello. Yeah.
Yeah, Satish. Yes.
See that definitely we are using this molecule, the ribociclib. I think as we have discussed till now. I am convinced actually then EBC that additional opportunity is there in high risk cases, because we only previously used to tell only the N2 disease and T3 N1 disease only we used to take it. But that was like we didn't understand that one actually, that even though the high risk no negative or even the N1 disease also were identified actually, that is definitely we are convinced to use in because to prevent the recurrent chances. And even advanced disease also we are the convinced, because this the molecule have a OS benefit, and you are to convince also that that's the one thing we are convinced in advanced cancer also in EBC.
Dr. Rachan, your final takes?
Yeah, I agree with Dr. Satish Sethi. We are convinced in adjuvant setting as well as in advanced cancer.
Dr. Arun, your final message?
Yes, sir. With the available data, we definitely agree with this. It has given an additional benefit, so I think it is a good to use the this molecule, sir.
Right. So with this, I would like to end my panel discussion. I would like to thank all my panelists for a wonderful panel discussion. And I would like to hand it over to Dr. Organizers and Dr. Lokesh.
Thank you, Dr. Karthik. It was an excellent discussion. Thank you very much. Most of the questions I think you have asked and answered. So I don't find any questions in the chat box. Okay, fine. Thank you very much. Then let's move on to the next session. It's sponsored by AstraZeneca. So by Dr. Kaushik from Command Hospital, Bangalore. So over to Dr. Kaushik.
Thank you, sir. Thank you, Dr. Lokesh, for the opportunity. So I will just share my screen, sir.
Yeah. Yeah, it's visible.
Thank you, sir. So, Dr. Thank you, sir. Thanks for the opportunity.
Can enlarge it.
Yeah, I think it's enclosed.
Yeah.
Thank you, sir. So my talk for the day would be on stage 3 non-small cell lung cancer, particularly the unresectable type, and what's the standard of care, and what's the perspective, and what is the changes which has been done for addressing the unmet needs in the stage 3 cancers. And being a sponsor section, disclaimers are the slides have been provided by the AC. So we'll be going through over the next 10-15 minutes in the slide as flashed. We'll be talking about the non-small cell stage 3, how we define it, what is the current standard of care, unmet needs, and what all has been done over there, and the data regarding the consolidation to improve the outcome per se in this set of particular set of cancer. So when you talk about a stage 3 non-small cell lung cancer, at present rate, we have around approximately 20 to 30% of patients who have their diagnosis in the stage 3 disease. But it's a very heterogeneous subgroup, stage 3, and 9th AJCC has divided into 3A, 3B, 3C particularly. And still, there are a lot of controversies in the division, the controversies in the management, particularly in the stage 3 cancers. So stage 3A predominantly, it's either N0 with a T4 or N1 with a T3, T4, or N2 with a T1, T2 disease. Stage 3 predominantly N2 disease, either with the T3, T4 or N3 with the T1, T2. And stage 3 is purely N3 disease with advanced tumor stages. So there are still a lot of issues with very grayscale in differentiation between the T2, 3A, 3B, 3C, and even in the management per se also a lot of controversies going on. So, and what's important in division, particularly why the emphasis in dividing the subgroup diseases, you can see in the lower down below, outcome per se. So once we see, based on the data available, the median overall survival data for 3A, it is to the tune of 42 months. And once it's in the 3B, it reduced to half of the 50%. So to the tune of 22 months. And in 3C, again, 50% reduction in the median overall survival data to 11 months. So it's the same thing, we can see the 3-year, 2-year, and the 5-year OS data. So 3-year, 5-year OS of 40%, 50% reduction when it 3B, that is 25%, and 3C again half of reduction to approximately 12%. So this is importance of identifying the particular patients in the 3 and giving a right treatment at the right stage of the disease. So what is the current standard of care? How we are managing the stage 3 presently with the unresectable one? Presently, it is the current standard is the definitive concurrent chemoradiation particularly, but there may be certain subset of patients who may be unfit for chemo or unfit for radiation, where certain approaches are used, the sequential chemo followed by radio, or induction chemo followed by concurrent chemoradiotherapy, or a concurrent chemoradiotherapy followed by some consolidation with chemotherapy. These are only for a particular subset of patients, but majorly the standard of care everywhere is concurrent, definitive concurrent chemoradiation. So what does the present guidelines say? Yes, once we stage the disease into the stage 3 unresectable and someone with a good PS, the standard of care is definitive concurrent chemoradiation, and subset of patients who are not candidates for concurrent chemoradiotherapy, they may have some benefit with the sequential chemotherapy followed by RT, or some patients who are not at all candidates for chemo, they may receive only RT alone. But majority should receive the definitive concurrent chemoradiation, and once we have a completion of the definitive CCRT, and once we have a disease response or a stable disease, in some subset of patients who are either EGFR positive, either it can be a DEL19 or a 21 LFPR mutation, the consolidation should be given with the TK, third generation TK, that is osimertinib. The data we'll discuss later on. And if it's EGFR naive, then the consolidation data with the PD-L1 durvalumab for up to 1 year. So this is the current recommended guidelines for management of unresectable stage 3 non-small cell lung cancer. So since we have this, we had the improvement with the concurrent chemoradiation, there were a lot of unmet needs because of the recurrences per se particularly. So there are a lot of data coming up for the consolidation treatment aspect. And we can see as flashed in all these slides and the available data, we can see a lot of attempt has been done for improving the consolidation part, either with the chemo, maybe a taxanes or a platinum combinations, or a TKA2, definitely was also used. But overall, when we see, there was no much of any benefit per se, or the significant benefit when these consolidation approaches were used in this set of patients. So based on this, and then later on we had the specific data. This is the phase 3 data from the specific trial in patients with stage 3 advanced unresectable who had either stable disease or a good response and not progressed following a definitive CCRT with platinum-based chemo. They were usually randomized within 1 to 14 days post CCRT to consolidation with the Durva, that is a standard dose of 10 milligram per kg 2 weekly for up to 1 year, and or placebo. It was a 2:1 randomization with the primary endpoint being a PFS and OS, and with multiple other secondary endpoint. What's impressive is the improvement in overall survival in the durvalumab arm when compared with the placebo. We can see the median overall survival improvement from 29 months in the placebo to approximately 48 months in the durvalumab arm with a hazard of 0.72. So at 5-year follow-up, we have a overall survival benefit of up to the tune of 42.9% in the durvalumab arm, the patients who had received 1 year of consolidation. We can see the KM curves starting separately from the starting and then maintaining that separation when compared to the placebo arm. When we see the subgroup analysis, the OS benefit across subgroup, there was benefit except for EGFR positive subset of patients. In this study, there were approximately 5 to 6% of the patients who were EGFR positive. And as we all know, they do respond very poorly for the PD-L1 agent. So except those subgroup, rest all subgroup had fairly better response with consolidation with the durvalumab. PFS data, yes, improvement is seen starting from the initial 2 to 3 months. From placebo for 5.6 months, the PFS improved to 16.9 months in the durvalumab with a 5-year PFS of 33.1% benefit when the consolidation was given with the durvalumab. So across again the subgroup analysis, except for the EGFR positive subset, rest all subsets, whether it can be a response rate, or whether it's a platinum usage, or whether it's a PDL12, the response was maintained with the all other subgroups except for the EGFR. So when we are called why the EGFR subset of patients who are not achieving such a benefit, so then there can be a lot of analysis and even the subgroup analysis from the real world studies or the Pacific R or data, where we can see in the Pacific data too, there is no much improvement when compared with the placebo group in those subset of patients with EGFR positive. Though the numbers were very low, the improvement was neither seen in the PFS or OS, and it was also reflected in the real world studies also. The much of difference or benefit with the PFS or OS with the usage of PDL1 consolidation. So how to improve that? Then we have the LAURA data. LAURA is the phase 3 study in those set of patients post definitive CCRT stage 3 unresectable who have either EGFR del19 positive or LAT mutations. These patients were randomized to 1:1 to either placebo or osimertinib 80 milligram once a day until disease progression or toxicity. Usually the median duration of exposure in the study was approximately 2 years per se. And the PFS, the primary endpoint, you can see the wonderful separation of the KM from starting from the initiation of the osimertinib maybe in 1 or 3 months, and the median PFS improved in the placebo. It was 5.6 months, to osimertinib it was 39 months with a hazard, impressive hazard of 0.16 per se. And the important, even in the investigator assessed arm also, the separation of curve was well maintained with the same hazard rate of 0.19. And benefit across all subtypes, whether it can be a stage, it's a 3A, 2B, 3C, or type of EGFR mutation, or a sequence of chemotherapy. Either some patient receiving a sequential who maybe not be initial fit for chemo, they may be received the sequential. They also had a complete PFS benefit across all subtype patients who have been exposed to osimertinib. And the important, we all know the osimertinib method good CNS penetration. So as suspected, there was significant risk of reduction in the CNS progression in this set of patients. It was almost not reached in the osimertinib when compared to 15 months in the placebo with a hazard of 0.77. And you're looking for the CNS events when the long follow-up was done on this study. The CNS events when were seen, it was to the tune of 41% in the placebo. These patients had the CNS events during the follow-up when compared to only 20%, almost half the reduction in the osimertinib arm. So reinforcing that osimertinib do have the CNS protective effect when exposed in this setting. So as flashed, the cumulative incidence of CNS progression at 1 year, that is on osimertinib, was 9% when compared to 36% in the placebo arm. The risk of progression was definitely reduced, and it was also seen as protective effect, which was important. So another secondary endpoint was the time to distant metastasis or death, which was seen. We can see there was a reduction in the time to in the placebo arm. It was approximately 13 months, which was seen when there was either a distant metastasis or death, but it was not reached when the last follow-up was in the OSIM arm with a hazard of 0.21. So this data reinforces the ability of this third generation TKI to prevent the distant metastasis, which is seen in those patients with EGFR mutated cancer, and the two in the post CCRT setting particularly. So safety summary, the grade 3 events, yes, they were observed in approximately 35% of patients. But however, the discontinuation was seen only in 13% of patients who have been using osimertinib when compared to 5% in the placebo arm. So pneumonia was a concern, and radiation immunity, because these patients have been exposed to concurrent chemoradiation and ILD and these have the history of smoking. So radiation pneumonitis or ILD was a concern, and it required regular monitoring this patient. Other than that, majority of the events we have been using osimertinib, it was all in the range of grade 1, grade 2, be it a rash, diarrhea, or paranoia, pruritus, skin fatigue, and they were all fairly manageable per se. So no major concern per se with respect to the adverse event in this study. So based on these two data, looking to the consolidation aspect of the stage 3 unresectable cancer, the present guidelines, be it NCCN, ASCO, and ESMO, all these recommend in those patients with the stage 3 deemed unresectable. So the next is the definitive concurrent chemoradiation, the platinum-based chemotherapy, minimum of 2 cycles, and once they have a response and there is no progression at all, and those with the EGFR, either del19 or L858 or subside, they do receive consolidation, should receive consolidation with osimertinib. And if not EGFR mutated, then the present recommendation is to consolidate with the durvalumab for 1 year during the follow-up period. So this is the across 3 major bodies, they have the recommendation per se.
Last minute.
Yes, sir. This is my last slide, sir. So this overall summary, what I can just summarize is, yes, stage 3 is not uncommon. We have around 20 to 30% of patients, and present standard of care, concurrent chemoradiotherapy, and with risk consolidation, yes, 2 data with consolidation, phase 3 data, the LAURA for those with EGFR mutated, and PACIFIC for those non-EGFR mutated with the durvalumab consolidation. And with across the subtype, it has been recommended per se. So thank you, sir. Thanks for the opportunity, sir.
Thank you for excellent talk. What's your experience with durvalumab? You consider
Sir,
2 weekly or 4 weekly?
So yes, sir. Actually, the data, the trial, it was given 2 weekly, but rightly said, it's difficult for the patients to again fall back after completing the CCRT for every 2 weeks. But we initially we started with 2 weeks if we have around 2 to 3 patients. But later on, since we have the benefit with the durvalumab of laxity of giving once in 4 weekly, so we gradually change it over to once in 4 weekly, sir. Though we don't have any data to support it.
Okay, you consider doing PDL1 based on that you will decide, or irrespective of?
Yes, sir. Yes, sir. I do that PDL1 because the later analysis of the data has shown that in those patients with PDL1 less than 1%, the benefit was not that great with the durvalumab. So yes, we do durvalumab, but and do stratify based on that, sir.
So maybe I think you will be having good experience because you can use for all your patients stage 3.
Still we
have a luxury of using for all.
So financial constraints are there, sir. So we have to stratify. So we do PDL1 when we see who is the one who do benefits with that.
Okay.
Thank you, sir.
Thank you very much. Yeah. Next.
Thank you so much, sir, for the wonderful talk. So our next session is sponsored by Roche. So I welcome Dr. Mansi Khanderia, Lead Consultant, Medical Oncology, Sparsh Hospitals, RR Nagar and Sarjapur Road. So welcome you, ma'am, for the talk. Over to you.
Thank you for that kind introduction. Thank you, Dr. Lokesh and Kidwai team for this invitation, and to Roche for this slide set. Can I share the slides? I'm not able to share it.
Sure, ma'am.
Right. I hope it's visible. Is it visible?
Yes, it's visible. Yes.
Yes,
Yes,
yes.
ma'am, you can continue.
Yeah, so I'll be discussing one case, which is real world case, which is a real case. The slides are made by Roche, but this is one of my cases which I'll be discussing at the end. So we all know that extensive stage small cell lung cancer was an alarming and aggressive malignancy, still is to some extent, but it used to be even more dreaded earlier. And platinum based chemotherapy was the historical cornerstone for a very long time till 2019, when Empower 133 established atezolizumab with chemotherapy as the first line standard. Now, however, we all struggle not only in this setting but in all settings about how long should we give immune checkpoint inhibitors. Is it 2 years? Is it just an arbitrary number? Is it something which we do for our mental peace? It is something which we can debate about. So, we know that this molecule was the first one to transform outcomes in small cell lung cancer. It is the only drug which has been studied for over 6 years now. We have some exploratory data. And it also now has a subcutaneous formulation, which is extremely useful in patients who go on long term with it. So, despite us having many more molecules now, of course, it makes our life easier and patients are able to afford. This is the standard drug which we started using and continues to show benefit. So, we know that it is a difficult to treat subset of lung cancer. Extensive stage small cell lung cancer accounts for about 15% of all cancers. And more than 2/3 of these are, maybe even more than, I think 3/4 of them are diagnosed with extensive stage. And before this approval, only 2% of patients, maybe they were lucky, whatever, I don't even know how many of them were actually surviving for more than 5 years with just chemotherapy. We do have some improvement in that. About 10% more patients in this study have survived over of more than 5 years. So till 2019, it was just platinum and etoposide. 2019, it became the first immunotherapy to be approved in first line setting. And now in 24, we had the 6-year data, and now with 2025, more than 230,000 patients have been treated worldwide, and now we can also use it in subcutaneous formulation. I won't go into the details of this. I think we've all studied this trial in great depths long ago. So this was a phase 3 randomized trial of extensive stage small cell lung cancer with Tecentriq in the experimental arm, along with the carboplatin and etoposide combination. And it reduced death by 30% and progression or death by 23%. And the overall survival was 12.3 months versus 10.3. So about 2 months of improvement in the overall survival was seen, and 30% reduction in the risk of death was seen. Progression-free survival again by about 1 month, but we do see it for a little longer in real practice, but about 4.3 versus 5.2 months, which would mean 23% reduction in the risk of progression or death, and 37% reduction for those on maintenance therapy. So 4 cycles and then maintenance. So those who were on maintenance therapy had 37% reduction in progression, and the safety profile was maintained. The adverse events were much lower, and we do see that in clinical practice that it is better tolerated than other ICIs. And the main toxicity is asthenia, fatigue, which we see in about 6% more patients than placebo. Of course, besides that, a little bit of thyroid issues we do see, but it's quite manageable. Rash is slightly more, but mainly thyroid related issues, asthenia, and some hair loss is what we see in real practice. Now this Empower 133 the patients, about 26 patients at the final cutoff, those who were on maintenance, just a single arm extension and long term observation was done in those patients. So out of 18, a subset of 18 patients were enrolled out of those 26 who were on maintenance, and they were studied for a prolonged duration. And after just till 6 years ago, 2% of patients were alive after 5 years. But in this study, it showed that about 12% patients were alive. So iUmbrella was just an extension of iEmpower 133, and it showed the 5-year exploratory OS data. So 12% patients were alive at 5 years. So due to the improved survival rates, of course, cancer patients are likely to seek treatment options that can bring them independence and impact their quality of life. So the quality of life was much better in these patients, and also subcutaneous formulation makes it even better. And there were no new safety concerns that were seen in these patients. Serious adverse events in about 28% patients were seen. So median OS, again 12.9, as this is another study where again the median OS was maintained. It's the same whether brain mets or not brain mets, the efficacy was seen across both the subgroups. Those with brain metastasis, treated brain metastasis, had a median OS of 15.7 months and untreated 10.2 months. And you can see that these numbers are consistent across multiple trials, be it iEmpower, Skyscraper 2, or KeyVibe. So about 12.9 months was an average that was seen. So the arms were well matched across trials, showing the benefit in all clinical trials. So it has the largest body of real-world evidence in studies evaluating responses with Tecentriq therapy. Median PFS range from 4.6 to 7.1 months. Like I said, we do see 6 to 7 months of PFS, and median OS from 6.8 to 20.8 months. About 25 studies and 9,800 patients have been studied, and it is recognized globally. It is the standard of care. NCCN as well as ESMO recognizes. Now, obviously, the question is, do we conclude it at 2 years or do we continue indefinitely, especially in an aggressive cancer like small cell lung cancer? Now, exploring the boundaries of maintenance therapy in exceptional responders to redefine long-term survival is something that we could debate upon. I don't think any of us have the right answer or the only answer. So that brings us to this patient of mine, which I had seen in my earlier workplace in Narayana in September 2021. He came to us with extensive stage small cell lung cancer with thoracic limited nodal metastasis. He had also CAD. He was post CPT-CA, hypertension, diabetes. He already had hypothyroidism, and an echo of a baseline was about 40 to 50%. So we could not give him cisplatin because of that echo. So we started him on carbohydrate, though in younger patients, we do give cisplatin over carboplatin, and atezolizumab was given. After 4 cycles, there was partial response, but it was good enough and it was still thorax limited. So after a multidisciplinary team meeting, we did think that we should give him thoracic consolidation in the thorax, as well as we gave a prophylactic cranial irradiation to the brain. After that, again, after detailed discussion, they were very motivated. So we continued 2 more cycles of carbo-eto, and atezo was also given. So after radiation and 2 more cycles, when we did the scan, there was complete response. And he was then put on atezolizumab maintenance. So this maintenance they took very regularly, every 3 to 4 weeks from 22 to 24. So that was 3 years after starting, and even then there was sustained remission. Then the patient started being a little concerned with the costs, obviously, because he was already on that, and we were not sure whether we should continue or not. We took opinions of multiple global leaders as well. And after a joint decision and informed decision making, we increased the interval from 3 weeks to 6 weeks. And he continues to be in remission. We've made it from 6 weeks to 12 weeks now, based on some understanding that the drug has some effect at least till 12 weeks after being given. So in fact, it's not November 2025. I saw him last Friday as well. He took his last dose last Friday. He continues to be in remission. He is due for his PET scan now, because now we are doing the scans only once in 8-9 months. And he continues to be in complete remission, very well tolerated. He had some neuropathy, which was also after carboito, but Atizo can contribute a little bit, plus his diabetes. He's on duloxetine for it. Just gabanuron was not enough. Thyroid is being maintained well with eltroxin. So I think he's finished more than 52 cycles. This was prepared in November when we first presented it. And going forward, of course, after the next PET, we will again revisit, and whether we should stop it or not is going to be a again shared decision making. We may actually stop it now that we have it. He's in that 12% of patients that we saw in the trial, but this is a real world patient. So he's that exceptional responder who continues to be in remission for so long. So just wanted to share this case with all of you. Thank you very much.
Thank you. Thank you. It was a wonderful talk. Any questions? Now, in the present available immunotherapy options, which is your choice?
So this is a tricky question, especially when I'm on a Roche sponsored talk. But no, I do
That's
offer.
okay. Keep aside. Yeah.
I do offer Tecentriq as first line.
Mhm.
But we do have good data from the Chinese molecules as well. All of them have some data, and based on the affordability, I offer each of them. I mean, there is no one favorite of mine. It's upon the patient's affordability.
Okay. Do you consider even the PCI for patient on immunotherapy now?
So I do, especially if it is shown, they have shown good response after 4 cycles, and it is a thorax limited disease, then I do offer PCI even now.
Okay.
We call it as Indian molecules.
Hmm. Okay. Okay. Thank you. Thank you very
Thank
much,
you, sir.
Dr.
Thank you.
Mansi. So next we'll move on to the next talk by Dr. Ravi T, consultant medical oncologist at Sparsh and HCG Hospital. He will be talking on a session sponsored by Intos. Over to you, Dr. Ravi.
Yeah, thank you, Dr. Lokesh, for giving this opportunity. Let me share my screen. I hope screen is visible.
Yes, yes, yes.
Yeah, thanks. So as we were discussing the previous talk by Dr. Mansi, I think a lot of new molecules have come, and Eternifly is one of the next generation IO which we are using commonly in many malignancies, and we will discuss the data in lung cancer, how it has changed our regular management. So we all know lung cancer is one of the common cancer which we treat on a day-to-day basis, and majority are NSCLC, but we do see significant number of SCLC because of the sheer volume, that is the number of patients we see. So automatically even the incidence is less, but we do treat SCLC also. If you see serplulimab global approvals, in India, it is approved for small cell lung cancer extensive stage. But if you take China, it has been approved in lung cancer across all small cell, non-small cell, squamous, non-squamous, and also in perioperative gastric cancer setting. And Europe also, the approval is more as compared to India. And if you see the ESMO magnitude of clinical benefit scale, the benefit of serplulimab as compared to Atezo and Durva, it has been rated high. So we'll discuss a few important trials for serplulimab. This is ASTRAID study where serplulimab has been compared with Atezo. It's a unique study, head-to-head comparison in treatment-naive small cell lung cancer extensive stage in US. The enrollment is completed. So unique in the sense that head-on-head comparison of one molecule versus other molecule, which is the standard of care. If you see the inclusion criteria, age above 18 years, small cell lung cancer extensive stage in the first line setting, 1:1 randomization, chemotherapy backbone remain the same. One arm received serplulimab and the other arm received atezo, and followed by maintenance. So what's different? Why not all molecules are same? We all know that though the mechanism is same action, but not all molecules are equally potent. So serplulimab is a novel anti-PD-1 monoclonal antibody of IgG4 subclass. If you take the binding affinity, it is 10 times higher than Nivo and 3 times higher than Pembro. So probably this is where these newer molecules stand apart as compared to the existing molecules. So we can see the structure here. So in contrast to Pembro, serplulimab binds to same epitope but approaches PD-1 at a different angle because its chains contribute differently. So because of this different binding and potency of the binding, probably the benefit may vary. So that's what the studies are. So it's a PD-1 receptor inhibitor with a different mode of action. It is significantly superior PD-1 internalization compared to Pembro and Nivo. So these are all PK studies, and preservation of CD28 mediated signal restores the T cell function better as compared to the Pembro. So these are all, I think, PK/PD studies which they have compared, and they have shown that these molecules are different, at least, though they are claiming the potency also is high. But at least we know that all these molecules are not same, and they have given the evidence here that serplulimab, why it is slightly better as compared to other molecules. So coming to small cell lung cancer phase 3, so we'll discuss ASTROM study. So ASTROM 005, so it's a randomized double-blind placebo-controlled global phase 3 study. If you see the inclusion criteria, they were all small cell lung cancer extensive stage. Again, first line setting. Stratification factors compared were PD-L1 expression, brain metastasis, and age. The primary endpoint of the study was overall survival. It's a 2:1 randomization. One arm received serplulimab with a standard chemotherapy backbone, and the other arm was placebo, followed by maintenance. If we see the population subtypes, 25% had liver metastasis, 13% had brain metastasis, which suggests that they were all having extensive disease. So 114 sites across 6 countries. So last year it was published in ASCO, 54 months follow-up. So if you see the results, the hazard ratio was 0.6. And if you see the delta, the magnitude of benefit was 4.7 months higher. So the overall survival here in the serplulimab arm was 15.8 months as compared to 11.1 months in the chemotherapy arm. And we can clearly see here the Kaplan-Meier curves, good separation, and we can see the tail of the curves. That is, a significant number of patients will have sustained deep remission. So updated OS, if we see the forest plot, those patients who had brain metastasis, liver metastasis, so almost all subgroup of patients derived benefit, and the benefits was consistent across all the subgroups. The secondary endpoint also was met, which was the longer PFS. If you see serplulimab arm PFS was 5.8 months as compared to 4.3 months. And we all know that in IO trials, the PFS will be shorter and the initial curves will be overlapping, but it is the tail of the curve which matters. So based on this, if we see the ESMO benefit, serplulimab is superior as compared to other molecules. And coming to the safety results, no, say, other than expected standards side effects of the IO, no new safety signals were seen in this trial. And if you see the treatment related adverse events, majority are related to chemotherapy only, and majority were grade 1 and 2. So these are the landmark trials for IO and chemo. So we are switching gears now for NSCLC. We know that there is good data for Pembro, Ipi-Nivo, Atezo. So we'll see how serplulimab fits into that space. So this is Astrum 004 study, where a phase 3 study of serplulimab plus chemo in the first line setting in advanced squamous NSCLC. Again, randomized study, phase 3. It's in the first line setting, advanced disease with no driver mutation. Again, stratified based on the PDL1 race and disease stage. 2:1 randomization. One arm received serplulimab and standard chemotherapy backbone, and other arm placebo. Maintenance was allowed. The primary endpoint was PFS. And coming to the results, we can clearly see here again a significant benefit. There is 45% reduction in the risk of progression, and median PFS of 8.3 months versus 5.7 months. So subgroups, so irrespective of PDL1 expression, stage, race, brain and liver metastasis, almost all subgroups derived equal benefit. And coming to the overall survival, again, a significant reduction in the risk of death. Clearly, we can see the Kaplan-Meier curves on the tail with hazard ratio of 0.49. Tumor response also was very good. That means it is beneficial to the patients because majority of our patients will be having high tumor load. And if the response, that is ORR, is good, the benefit will be very early. Safety profile, again, no new safety signals and very well tolerated. So what we can conclude, serplulimab, when added to the standard chemotherapy backbone, it significantly improves survival, PFS and OS in first line setting of squamous NSCLC. So it is one of the good options among the available options. So coming to non-squamous lung cancer, Astrum 002. We'll discuss the final analysis of first line serplulimab with chemotherapy, with or without a VEGF inhibitor will benefit or not. Again, a randomized phase 3 study. So again, in the first line setting, advanced disease, no driver mutation, stratification factors were similar based on the PDL1, smoking history and brain mets. If you see, this HLX04 is a bevacizumab biosimilar. So serplulimab plus bev and chemo, serplulimab and chemo, or only chemo. These were the main three arms which were compared, and maintenance was allowed. So baseline characteristics were well matched. So if you see the results, serplulimab plus chemotherapy again has good benefit. There was 47% reduction in the risk of death, though there was a crossover, but the benefit maintained. And subgroup analysis, all the subgroups derived equal benefit. And if you take the PFS, again, significant benefit, 46% reduction in the risk of progression. Again, in PFS also, all the subgroups derived equal benefit. So the authors concluded that the addition of serplulimab to chemotherapy significantly improved the overall survival. One more additional thing what came out from the study was adding bev to serplulimab didn't add the benefit. So serplulimab plus chemotherapy was sufficient. And both PFS and OS has got meaningful benefit. So the combination therapy of serplulimab and chemotherapy is again one of the first-line treatment options for NSCLC. Adding BEV to this combination did not confer additional survival or clinical benefit. So with this I'll conclude. Thank you for the patient hearing.
Thank you, Dr. Ravi, for a wonderful talk. Any questions? So again, I am asking same question. What do you prefer? You go for serplulimab or other IOs as earlier?
Yeah, I think now the good thing is we have got multiple options. That is good for doctors and patients. Earlier it was a monopoly. We remember when IOs came, we used to write whatever is the PAP program was there. So now that is not there. Because of these molecules, I think the innovator molecules also have relaxed their PAP. So if you ask among the available molecules, I think all the molecules are good in their own terms. But what we have seen is when we come to the data, I think if you see the benefit, these Chinese molecules, at least what we can see and in our own experience, the responses are good. And so earlier we were very skeptical how these molecules will fare, but definitely when we see the results, at least what we can say is they are equally good as compared to the MNCs which are available, and that we can conclude.
Yeah, they have done only in Chinese group of patients. With that evidence only we have to use.
Use it, yeah.
Yeah. We are waiting for real world evidence at least, if not a clear cut studies. Okay.
True.
Fine. If no more question, we'll move on to the next talk. Sponsored by Glenmark, Dr. Srinivas KG, the senior consultant medical oncologist from ClearMedi Radiant, Mysore. So over to Dr. Srinivas.
Hi, Dr. Lokesh.
Hi.
My slides are visible?
Not yet.
Now?
No.
Sir, we will share from our side.
Please.
Yes. That would do the needful.
Okay. Visible.
So, good evening. Thanks. I thank Dr. Lokesh and Glenmark for giving me this opportunity to talk on personalizing CINV prophylaxis. What are the lessons we learned from the MIRIS trial as well? Next slide. So, the patient's related risk factors for CINV remains inconsistent across the guidelines. Some of the guidelines says a combination of 4 drugs, some of them say 3 drugs, but still we are not very much convinced about what exactly the combination can fit into the patients who are actually in need of antiemetic drugs for which particular regimes. So individual risk factors are considered very important, but they are not part of the prophylactic treatment algorithm for CINV, because though it's very important for us to know the individual risk factors, because that is the one which will actually pose them a risk for emesis. Next slide. So some of the individual risk factors like female, young age, history of chemotherapy, anxious personality, and the minimal alcohol use, history of emesis during pregnancy, history of motion sickness, all those actually may be important during evaluation or counseling regarding the chemotherapy, particular chemotherapy regime. And I think one needs to know in the history of these things so that we can properly tailor a particular antiemetic protocol. Next slide. So we generally talk about what the risk levels, whether it is high or moderate or low or minimal. But when you follow this kind of a protocol, there are some limitations, because if you talk about the moderate emetogenic risk, the risk of emesis without emetic ranges from 30 to 90%, which is very wide range. Of course, I don't think it will fit in one size, because it's a very broad range what you call it as from 30 to 90%, though it is widely accepted model, but still it comes with a significant limitation. Next slide. So as I said, one size fits all approach is not only for antiemetic protocol, but also for, we talk about tailored therapies or precision therapy in each and every aspect of oncology in different settings. Of course, this also holds good for antiemetic protocols. Of course, one size cannot fit all the moderate emetogenic regimes or settings. Next slide. So if you see the guidelines, we generally categorize them into the risk group, whether it is non-AC regime or AC containing regime, where the quadruplet combination like 5-3, dexamethasone, NK1 and olanzapine is added. And if you see the moderate risk, when we generally we use 3 drugs with 5-3 or dexamethasone and NK1, or if it is low, only 5-3 with or without other drugs, at least 2 drug combination would be there. So the emetic potential of ADCs, what we talk, because with the increased availability of ADCs now, so we talk about ADCs, whether it is sacituzumab govitecan or trastuzumab deruxtecan or datopotamab deruxtecan. I just had a meeting with Astra yesterday where we were talking about the Tropion trials, where now there is a huge potential for TNBC first line regime. So these ADCs are also of high end of the moderate category. So they may also come to like a borderline or a high end of the moderate emetogenic potential, closely resembling that of a carboplatin chemotherapy. Of course, while prospective studies are needed, it is suggested to prevent emesis as of like a carboplatin. Probably when we use an ADC, probably our mindset to be towards almost a high risk kind of thing, so that where we may have to use 5-3 plus dexamethasone plus NK1 with or without olanzapine. So when I was a PI for DB09 trial, where we had 6 patients for trastuzumab deruxtecan, initially the amendment was only to use a 5-3 plus dexamethasone, not even a NK1. But after some time, they had revised an amendment saying that NK1 has to be done because a lot of emesis as an adverse event is seen in these patients. So later they actually refined the amendment saying that NK1 has to be added. So I think the guidelines also keeps moving, the protocols keep changing depending on the lessons what we learn in over a period of time. Next slide. So we all pretty familiar with protocols and the antiemetic guidelines for moderately emetogenic chemotherapy. If you see again in NCCN guideline, again there is no consensus on the inclusion of an NK1 receptor agonist in patients with additional risk factors like what I told, anxiety or high treatment expectation of nausea, vomiting, history of CNV or motion sickness. All those may not be included in these, even in these guidelines, but future studies should systematically include patient-related risk assessment in order to define the risk of emesis with the moderately emetogenic potential beyond the emetogenicity of the chemotherapy regime itself, which can improve the guidelines for new drugs. Next slide. So this is a article which was published in ESMO and in Annals of Oncology on personalized antiemetic prophylaxis with NEPA for patients at high risk of chemotherapy-induced nausea and vomiting receiving moderately emetogenic chemotherapy from a randomized MyRisk trial. Next slide. So, of course, as I told, focus on risk factors are very, very vital and central to in order to tailor the particular combination of antiemetogenic drugs, antiemetic drugs. I mean, next slide. So the objective of MyRisk trial was to see that whether NEPA plus dexamethasone versus 5-3 plus dexa, which is standard of care, across 3 cycles of moderately emetogenic chemotherapy cycles. So an algorithm was used to identify patients at high risk of CINV, and only patients with a high CINV risk score were included in the trial. So if you see the predictive risk factors like less than 60 years, patient reported expectation of nausea and vomiting, history of morning sickness, and who are all the patients who are receiving a platinum or anthracycline containing regime, and non-prescribed antibiotic at home in the prior cycle. All these risk factors were taken into consideration, and the score was given. Next slide. So the background is why NEPA? Because it is chosen for its unique pharmacological profile, which has a longer half-life and higher receptor occupancy in the brain, and significantly better CINV control compared to other NK1 receptor antagonists like a conventional old-time aprepitant or efosaprepitant. Next slide. So this is the design of the MIRIS study. It was a phase 4 interventional open-label randomized active controlled parallel arms with a multi-center multinational trial. So stratification factors were like whether carboplatin used or not used, and what country or what origin of the patient. So patient receiving moderately emetogenic drugs, so they were categorized into high risk moderately emetogenic patients, and then they were randomized to NEPA plus dexamethasone or a standard of care any 5-HT3 receptor agonist with dexamethasone. Next slide. So the primary endpoint was complete response, which is defined as no emesis and no rescue medications in the overall phase, which is like a duration of 0 to 120 hours post chemotherapy across 3 consecutive cycles of moderately emetogenic chemo drugs. So the secondary endpoint was during the acute phase or a delayed phase and overall phase across 3 cycles, the CR or complete protection, no emesis, no nausea, no rescue medications, and quality of life and the safety. Next slide. So this is the patient demographics. If you see, half of them were females and half of them were males, and with a good performance status of ranging from 0 to 1. Only 2% of the patients were ECOG 2. And if you see the chemo naive patients were majority, around 75% of them in each group were chemotherapy naive. That means they were taken for the first time these chemo drugs. And the most common cancer types was like colorectal, lung, ovarian, breast, and others. Thank you. Next slide. So the primary endpoint, if you see the complete response across 3 cycles, so the odds of achieving an overall complete response in any given 3 cycles across chemotherapy were significantly higher with the NEPA containing arm compared with standard of care. If you see the 81% was a 71, which is very obvious. The odds of achieving it were very higher in NEPA containing arm. Next slide. Again, even the secondary endpoints, the odds of achieving a CR in any given cycle across 3 chemo cycles were similar in the acute phase, but significantly higher with NEPA during the delayed phase as well. So we all know that acute phase is okay, but also delayed phases, which is more important to achieve a complete response for nausea and vomiting. I think the delayed phase is what the clear winner. The NEPA makes a very clear-cut distinction in a delayed phase, which is very, very clear that NEPA has an advantage over other drugs. Next slide. So even no nausea rates were consistent, were higher with NEPA in the delayed and overall phases in each chemotherapy cycles. So this is again very important because we say the actual emesis has not taken place, but even the nausea is also equally a discomfort to the patients. So if you see, even across 3 cycles, there are no nausea rates were seen much in NEPA containing arm, significantly saying that the nausea, the control of nausea was significantly higher in NEPA containing arm. Next slide. So even the subgroups, if you can see, the estimated CR and no nausea rates were higher in the NEPA group across the subgroups than compared to standard of care during even a delayed and overall phases in this subgroup of patients. So which is common, which is very clearly saying that across the subgroup, the NEPA made an impact for a delayed emesis prevention. Next slide. So, in fact, if you ask the impact on a daily living across 3 cycles, even if you see the total domain or a nausea domain or a vomiting domain, the NEPA containing arm was significantly better compared to the standard of care group. Next slide. So if you see the adverse events, we all know that we are all quite been using NEPA for many indications at so many patients. And I think one of the very safe drug what we have come across, if you see the treatment emerging adverse events related to study drug, it was around 18% to 18.5%. But if you see the discontinuation rate, it was only 2.6% in NEPA and 3.4% in standard of care. And if you see the treatment related deaths, it was equal in both the groups. So the safety profile of the NEPA and standard of care arms were comparable with no significant difference observed in both the groups. Next slide. So to conclude, NEPA plus dexamethasone was superior to 5-HT3 plus dexamethasone in preventing chemotherapy-induced nausea and vomiting across 3 cycles of moderately emetogenic chemotherapy in patients with elevated chemo-induced nausea vomiting risk in these patients. And superiority was consistently observed across several secondary efficacy endpoints, including no nausea, which is typically the most challenging symptom to control. I think all onco physicians who practice would agree with me that nausea is something very challenging in our day-to-day practice, and patient doesn't feel happy about it. They stop eating. They tell that I'm not feeling like eating. I lost my appetite because of nausea. Somehow I'm not comfortable. I think this MyRisk actually has clearly shown that even we can achieve a complete remission or a complete response, even as far as the nausea is concerned. I think consistent with overall MyRisk trial results, NEPA demonstrated a superior CINV prevention compared with standard of care in the patient subset representing an unmet clinical need, where current guidelines recommend only 5-HT3 plus dexamethasone. Even for that matter, if you see the ESMO guidelines, they don't mention NEPA in a moderately emetogenic risk. Probably, I think there is a huge unmet need, so that we need to address it. And I think MyRisk clearly shows that even in a moderately emetogenic potential having regimes, I think we need to use NEPA as a very important as a part of the protocol, so that patients' quality of life is maintained and no nausea rates are very, very less, and definitely they have a significant impact on their quality of life. Next slide. So MyRisk trial highlights the clinical value of a personalized approach to antiemetic prophylaxis and demonstrates practice-changing potential in addressing an unmet need in the management of delayed chemotherapy-induced nausea and vomiting. Next slide. Thank you. Thank you again, Dr. Lokesh and Glenmark, for giving me opportunity to talk on this topic.
Thank you, Dr. Srinivas. It was excellent talk. So any questions, anyone? Now, do you use all 4 drugs for highly emetogenic?
So I think with availability of NEPA, definitely moderately emetogenic drug, I use 3 drugs for sure. NEPA, 5-HT3 and dexamethasone. Because as I told you, we think that antibody drug conjugates are not emetogenic, but they are bad. As far as emesis is concerned, all your antibody drug conjugates are on the high borderline of moderately emetogenic, almost like they behave like a high risk. I think that's what we have learned. I think we need to use NEPA in these kind of settings. I use NEPA whenever I use any antibody drug conjugate, whether it is Ujvira, whether it is TDXD NR2, whether it is Sastimab Govitecan, whether it is Brentuximab Vedotin. I use NEPA in all the patients where I use ADCs.
Yeah, definitely. I do really prefer for all highly emetogenic using NEPA. Only issue is if patient is not able to take orally, the issue arises that we have to.
We have even IV NEPA for that matter.
Yeah.
So
IV NEPA.
I do use a lot of IV NEPA as well. So if somebody is not able to take oral, I also prefer IV NEPA as well.
Okay. then.
Thank you, sir. So final remarks, final closing remarks
Okay,
from
fine.
Dr.
Thank you, Dr.
Lokesh.
Srinivas. We have come to the end of day one. I would like to thank all the speakers, all the moderator, panelist, everyone for giving their valuable time for the discussion. Thank you very much. All the attendees, thank you very much. So I'll close the day one. Tomorrow, let's start the day two with the GI and GU session followed by the hematology. Thank you. Thank you, one and all.
Thank you, sir. Thanks to all the panelists and the moderator and the speakers for today's webinar, taking out their time. And thank you, sir. Thanks to my colleague, Daud, Manya, and Shagun, and the technical support. Thank you, everyone. Good night, everyone. Stay safe. We'll meet tomorrow.